So we are going to go live in 5, 4, 3, 2, 1. We are live.
Okay.
Okay.
Good morning, everyone.
Yeah. So, good morning, everyone. On behalf of orthotvonline.com, we welcome you all to the shoulder arthroscopy webinar, which is brought to us by Sironix Arthroscopy Solutions of Healthinium Company. We have Indian Arthroscopy Society Secretary, Dr. Sarnanendu, and Dr. Sergio from all the way from Brazil. It's 1:30 a.m. for him, and he is staying online with us.
Yeah.
And, we have all the panelists now coming online. So over to you, sir.
Yes, this is a great honor and privilege that I welcome all the faculties. Like we are really honored. Sergio from Brazil, he's there. He's always telling, okay, there's no problem. He will join. Vivek is my brother. He's a very close friend of mine. Jaya is also there. Manish is going to come. Neeraj is going to hold the technical aspect and forward the question to us, whatever question is coming to this forum. And also Manish will be the main moderator of the program. I will just assist him. So Neeraj, we can take the, as because 10 o'clock our respected beloved Prime Minister is going to address the nation, and meeting was prefixed at 10 o'clock. So we could not change the mid timing of the program. We are sorry for that. Really sorry for that. And for that, because this program is completely merging with the same timing with our respected PM, we will take the questions from the those who have logged in, or else we'll start with one case so that we can discuss something. And once we can answer your questions, then we by 10:15 we'll go with the lectures. Is it okay, Sergio?
Yes. Yes.
Okay, Vivek.
This is the pre-op. This is the pre-op AP view, and then we have the just for people to understand. This is a case that I operated 12 years ago, and this is the AP view, and then we can see the CT scan. But do you want me to comment, sir, or do you want to make comments, sir?
Yes, this was a post-traumatic, Sergio.
Yes. See, this was a very, very obese lady. She was 50. She fell when she was coming from a bus, and she fell in abduction, external rotation, and she came with a lot of pain to the emergency, a lot of swelling in the right shoulder, and that was the AP view, in which we can see. This is a well-done AP view. She was with a lot of pain, in which we can see a small bony Bankart fracture of in the right shoulder. And the thing is that it's extremely important for us to see these lesions through CT, for us to determine whenever we shall operate it or not. So I guess that Neeraj can show the CT, and then we can discuss. Yes, so this was the CT, a big fragment in a 50-year-old very, very obese lady. If someone wants to make any comment now.
Vivek?
Yes, sir.
You are going to take this? Obese lady, fresh trauma.
Very obese. Very obese.
Very obese.
Very obese.
Very fresh trauma.
Fresh, yes. That was on the day of the trauma. She was in very, very big pain. And I'm quite sure that there is a 3D CT, which is something that, well, Vivek can comment, of course, but I think that nowadays it's a very interesting tool, especially if we can have suppression of the humeral head. It was 12 years ago, but Neeraj can show us now. But I'm quite sure that this is a LET view in which we can see a bony Bankart, an important bony Bankart, and now the discussion is leave it or fix it. I guess that would be before showing what I have done, to discuss why to fix it or why not to fix it.
what was the age of the lady?
50-year-old lady, very, very obese. And she was how can I say, she used it to sell things in a small shop.
And what was the status of cuff?
The shoulder was absolutely perfect until the trauma. She was absolutely okay.
Even after the trauma, what was the status of the cuff? Was it normal? Because in elderly people, when they have some kind of dislocation with or without bony Bankart, they may rupture their cuff. So
I absolutely agree. No, I absolutely agree. I absolutely agree. See, when you have middle-aged patients, when they dislocate the shoulder anteriorly, I would say that until proven contrary, there is a traumatic cuff tear. But the case is that she didn't dislocate. She didn't. The shoulder was not dislocated and was not reduced. She came with the shoulder was not dislocated, but that's how she came to us.
No, I mean, that's what, see, this kind of a fracture where in one image and the other image, it looks like it's almost involving one part of the glenoid. Okay. And it's in the end, this fracture is involving, whether you want to call it as a bony Bankart or almost reaching like a glenoid fracture, it's almost involving the 1/3 of the glenoid. Okay. And she's 50, she's active, obese or not, it's not the question. She's active, she's doing some work elsewhere. So I feel that it has to be fixed because it is not undisplaced. It is a displaced fracture.
Yes, so that was exactly what I thought. You see, it's a bony Bankart, but in my opinion, it had something about one third of the I would say of the area of the glenoid. It was a displaced fracture. We thought at that moment, that was 12 years ago, we thought about, well, maybe if we don't fix it, is the shoulder going to be stable? But the thing is that there is one other thing that I think we should consider, that fixing it in the acute setting is possible, but fixing it in a chronic scenario is absolutely impossible. So one more reason to fix it. In my life, I have already done a similar case 2 months old, and the reabsorption of the bony piece was absolutely huge. Just a second, sir. And I had to do a Latarjet. So in this case, if there is one chance to fix it, is in the acute scenario, and this is what I did. And see, I don't have an arthroscope in my public hospital, so I had to do it open. And
I have a comment to make. If you carefully see the CT, you see there are very early already arthritic changes happening in the inferior aspect of the head. And the acromiohumeral space is very less. Okay, it's perhaps
I completely agree. But the thing is, until 2 hours before this CT, her shoulder was absolutely fine. She was living her life. She had nothing until the trauma. So in my opinion, it had to be fixed. I would love to do it arthroscopy. Yes, sir.
You know, how about the neurovascular status, Sergio, before going ahead for the surgery? Any axillary nerve injuries there?
Oh, this is something. Yeah, she had a post after the surgery. She developed an axillary nerve palsy that was resolved after 3-4 months. The final result was outstanding, but I think that the discussion in my mind is why to fix it or not, and how to fix it or not. Because see, in my point of view, this is something that you must absolutely know how to deal with the subscap. And another thing that is absolutely for sure, that the surgeon must be prepared, and I discussed that a lot. It was 12 years ago, but I would do the same thing nowadays. You must be prepared if you don't be, if something very bad happens intraoperatively, you must be ready to do a Latarjet as a card on your sleeve. So this is something to be kept in mind. What I did is that I opened the subscap just like in a shoulder arthroplasty, just like in a reverse. And I entered it with a Fukuda, and then you pass 2 or 1 screw. And there's another nice discussion, which is, well, 2 screws is better than 1, because of with 2 screws, you have an anti-rotatory effect. But see, with 2 screws, I was very afraid that the bone piece would explode, because it was very tiny. So I was happy with 1, and that's it.
Sergio, it is a very big piece.
Yeah.
Yeah, fracture starting from at 3 o'clock to towards 7 o'clock. It end is at 7 o'clock.
Yeah.
If it is breaks also, the lateral jet may not suffice. It inferior part, I think inferior part is a main important thing, like 7 o'clock to 6 o'clock.
Sure.
So
you
that
are
area may not be fulfilled with your lateral jet. That
what
may
I
be-
said. You
So
are
you have to
completely
fix it.
right. No, what I said is a Latarjet would be a plan B or a plan C or a plan D. Only if something very difficult happens intraoperatively in a way that you cannot fix it. But see, with delicacy, we can fix it. And see, I was extremely afraid of putting a second screw, and the purchase was very good, and I was absolutely happy with that. And then I fixed it. I made a transosseous reattachment of the subscap. Obviously, I did a biceps tenodesis, and well, and that was it. And you see, just one thing. This is something about 2 or 3 weeks, 2 or 3 days post-op, and if you see, the humeroacromial space is enlarged, because she developed, as the vast majority of these cases do, she developed an deltoid transient atony because of neuropraxia of the axillary nerve. I see this in basically in at least 50% of the proximal humerus fractures that I do. Yeah, and over time, something about 4 weeks, 6 weeks, the axillary nerve recovers, and then the humeroacromial distance becomes normal again.
Have you added any anchor apart from your screws?
No, no, it was just 1 screw. And you see, the anterior-inferior glenohumeral ligament was attached to that piece. So once you fix that, the anterior-inferior glenohumeral ligament comes back to its anatomical position.
Okay, Sergio. So now we welcome Dr. Manish Maheshwari. He is from Indore, and he is the moderator of today's program. So he will
Hello, sir.
He is the boss of today's meeting. Okay, so he will moderate the questions, and he will float the questions to the particular faculty if it is there. Hi, Maheshwari, you just go ahead. What is your opinion, Manish, for this case? You have to unmute. You have to unmute. You have to unmute. Yeah, it's done.
I joined late, so I missed this case initial discussion. So difficult for me to say, but I think Sergio, as usual, has done a great job. So spare me for this case. From next case onwards, I mean.
Okay. Thank you.
Yeah. Okay, sir.
Yeah.
So you see, if Neeraj can show, the final result was very good.
Yeah.
Yeah, and yeah, a good result. And the thing is, many people say, and I just want to highlight one thing, okay? And it's the same idea of shoulder arthroplasty. When you do the reattachment of the subscap, you must do it in something like 30 degrees of external rotation. If you do it in full internal rotation, then gaining external rotation will become very difficult over time.
Yes.
So this is something for all of the audience to keep in mind.
Yeah. Yeah, that's a very good point, Sergio. Yeah. Because when we do that subscap reattachment, then it has to be like 20 degree of extra. Otherwise, it is very difficult to regain the functional range. Not that terminal 10-15 degree, but to regain the functional 10.
So you see, so you see in the other image, the external rotation is absolutely normal because the subscap was reattached in a very good position, something like 30, 35, 40 degrees of external rotation. And another thing that I want to comment is this. The older I get, the more I understand that the best way to do a subscap reattachment is with nothing but transosseous sutures. Many people like to do it with anchors, is never wrong. But in my opinion, doing with transosseous works very nice.
Okay.
I think we can proceed, Dr. Samantha, because the PM has already announced the lockdown extending, and I think most of the people will gradually join. So I think we can gradually start.
Okay. We can go ahead.
So I would like to announce here from Ortho TV that 1800 people are already watching us.
Osteoarthritis, sir.
How many?
1800, 1800 people are already alive with us.
Okay,
so we can go ahead with the presentation.
That's a great number. Okay.
Very good number.
Sergio, how is the joint now after 12 years of your repair?
Excuse me?
How is the joint now? Is it developed in osteoarthritis or is okay?
You mean this lady?
Yeah.
The thing is, I'm going to give you a very serious and honest response. She disappeared, but 6 months ago, she found me on Instagram. And I said, do you remember me? I'm very fine. My shoulder is very fine. And I asked her to come back because I wanted to do neo X-rays. So what I can tell you, until 6 months ago, she was good. But see, in my opinion, this is a very good question and a very easy to answer. Post-traumatic glenohumeral arthritis in such a case, until proven contrary, it will come. In my opinion, it's not a matter of if, it's a matter of when. Yeah, sooner or later it will come. But there is a big advantage in the shoulder because the hip is a compression joint and the shoulder is a distraction joint. So because the shoulder is a distraction joint, all of these, I would say, post-traumatic glenohumeral degenerative phenomena are much more tolerated by the shoulder. But you see, I would like to see her again. I asked her because she found me on Instagram, on social media, but she didn't come. But until that, I would say clinically she was very happy and stable.
Okay, Dr. Samantha, we need to start now.
Is it ready?
Yeah.
See that?
Yeah, we need to start now, sir.
You have seen that now? Is screen?
Yeah, we can see.
I would request every one of you to mute their screen and put off their video so that basically only Dr. Samantha's face is seen.
Okay. Go ahead, Manish. Can I go ahead?
Yes,
How
sir,
do I do this?
Okay, so today we are going to, this is the first lecture of this meeting. So I am going to discuss very, very basic aspects, how we read the MRI of shoulder. So because we have all been graduated through our eyes that from the knee MRI. So if we can understand the T1, T2 or the basic sequence of how to read the MRI, then we probably have seen some of the MRIs of the knee, then only we can graduate to the shoulder. So in this lecture, I'm not going to give you very hi-fi stuff, just what are the basic sequence and how we take the sectional anatomy, what is the normal MRI structure in a normal shoulder, and what are the common pathologies. we know from the knee MRI we take, because we orthopedic surgeons are not very intelligent. We are clever rather. So we take the T1 and T2. So basic idea of T1 is that when you see this sort of T1 image in the knee, once you see this infrapatellar pad is very bright and white, then you know that this is the T1 image. Okay. So in T1 image, what you are going to see? You are going to see the bone marrow and the subcutaneous fat are bright signal. So if the subcutaneous tissue and the bone marrow is giving you the bright signal, then you take it as a T1 image. The ligaments and tendons are dark in T1 and muscle is intermediate to low signal. So then we go to the this image. Okay, so here in sagittal T1 fat sat image, this brightness, you see this brightness is changed. Okay, then the bone marrow and the subcutaneous fat signal is now suppressed, and any enhancing process we give like your gadolinium, we can have the better picture just to have the contrast image. So when we come to the T2 image, you see now the fat, your fluid is coming very bright. Fluid is coming bright and your fat signal here is not that bright. So if the fluid is bright, then you take it as the T2 image. So bone marrow at fat signal is diminished in comparison to T1 spin image, and joint fluid is bright signal. So this much of knowledge we from the knee we get, and that we translate to the when we see the MRI sequence of the shoulder. So in MRI 6, like in knee, we take the coronal cut, sagittal cut, and the axial cuts. Here also we take the axial cut. So the top picture on the right corner, you see this one is the axial cut. Okay, so this is the axial cut. Then we take the coronal oblique, this one, and then we take the sagittal oblique. So this is the way we go ahead with your cuts in the shoulder. So if we remember the anatomy, suppose how we go with the axial cuts, this is the way how we see the axial cuts. This is the glenoid, this is the humeral end. How you know in the front and back? Because you see, if you see the biceps over here, this is the bicipital groove, always it come front, and the head is always retroverted. So you know that this part is the front and this part is the back. Okay, and also you can see this is the subscap and this is your infra. So this is the subscap and the infra that makes your the force couple, and your this retroverted head and the biceps will tell you that you are coming from the front. This is the back side. So if you correlate that anatomical picture in your brain into the MRI picture, you see now it is very difficult. It is very easy. This is the subscap, this is the infra, this is the glenoid, this is your anterior labrum, this is your posterior labrum, this is your bicipital groove, and this is the biceps. And this part which is covering whole thing is your deltoid. Okay. So now you come to the coronal picture. So again, you have to think this picture in your brain, that how the coronal image is going to come. So this is your supra, this is your subscap is coming, this is your glenoid, this is the superior labrum. This is, remember, this is the superior labrum, and this part, this is the muscular part of your supra, and this black part which is coming over here, this is going to be your tendinous part of your cuff. This is the supra part. So this, if you correlate to this picture, so this is the bulk of your muscle of the supra. This part with where the signal is which change, this is the tendinous part, this is the superior labrum, and this is the humeral head. Then we come to the sagittal oblique. So if you see the sagittal oblique this way, then how you know this is the front and back? So you have to look to the acromion, because if you look to the acromion will always go from back to front. It will go in a upward direction. You remember that anatomy. So this has to be like this. So this becomes the supra, this becomes the infra, this becomes the teres, and this becomes your subscap. So these four muscle, they form you this your cuff. Okay, so this becomes your, so this is your subscap, this is your supra, this is your infra, and this is your teres. Okay, and this is the acromion. How you know which is this? So this has to be the front. So this is the way how you look around. This is the muscle, and this is the tendinous part. Again, you come forward, you can see the coracoid here. So you are coming to the front. So this is the other way you see. You can even see the AC joint. This is for backside. This is the anterior. So you know that this has to be the subscap. This has to be the infra. So this is the way now the supraspinatus tendon. You see, you have remembered that now you can see the whole tissue is not homogeneous. There is some white shadow over there. So it is not a full bone tear, but it is a tendinitis or a tendinopathy. Can you see there is some white signal there? Okay, Girish is joining. Okay. So now you remember there are some, this is the, you see, there are different tear pattern. Like I remember like ABC. A is the articular side tear, B is the bursal side tear, C is the complete tear, and this is the intrasubstance. So you see, if this is a partial articular substance tear, then it becomes the pasta. You see, is a partial articular surface tear. Then this is the bursal tear. You can see there is a top side tear. Then you can see this is the intrasubstance. This black arrow is in the, because some part of the calf is over here, some part is on the articular side. This is another one complete tear. You can see now it is coming to the glenoid. There is nothing is there. This is the fluid. So Boutelier has classified how you, when you see this Y sort of shadow this way, then you see this is the muscle bulk. So you have to see how much is the muscle curve before you embark on the rotator cuff repair, because by one, there is some fatty streaks are there. It is less than 50%. The more is the muscle, less is the fat. But if it is more is fat, then it is grade 3. If the whole more or less like white shadow, then it comes around. So now whenever you go in this shadow, if this is a tangential line, the muscle comes below, then there is more fat. This is the volume theory. So this is the IGHL, this is the torn IGHL. Can you see that? So this is the acromion shapes. You can even see a Bigliani 1, 2, 3. And this is the, once you see, this is the normal biceps. Now you can see there are a lot of fluid around the biceps. So this is going to be bicipital tendinitis. This is the way how we can see the subscap. This is the anatomy. You can see the subscap is going to be torn here. This is the way how you see the Bankart lesion. You can see this is the Bankart. It's more or less going to the ALSA sort of scenario. Anterior periosteal sleeve avulsion. This is the posterior. This even you can see the posterior. Even there is some gap on the this is the white shadow. The fluid is going there. So this is the posterior cuff. This is the superior labrum. I told you when I discussed about the normal anatomy. The fluid is going in. So this is the superior labrum. This is the biceps ankle lesion. This is anteroposterior. And sometimes you can see the, when it's a big one, you can see the suprascapular notch there. So heel sacks also you can see over there when you study your anatomy, because when you go into the instability repair, you have to find, then probably when you discuss by Dr. Vamre and other faculty like Vivek and Sergio will discuss when you talk about the instability. See, even sometimes the occult fractures can be diagnosed by your MRI. So this is for Sergio. So when this is the last slide. So this is written in Hindi. So you are learning the Hindi. Chalo, Dr. Saab. So when the last call will come for us to go for the last journey, then still we at the, we'll say, bus ek aur marij dekh lo. That means please allow God for 5 minutes, 5 seconds. I will see this last patient. So medics are different breed. We are born to win. Thank you. Take care. Stay safe in this pandemic COVID scenario. Thank you.
Thank you, Samantha sir. It was an excellent presentation. Hello.
Yes, hello.
Sir,
Hi,
it
Girish.
was
Hi,
excellent.
Girish, you have to unmute, Girish. Girish is not, Girish is muted.
Yeah,
Okay.
Samantha.
Yes.
So
Yeah,
for
Dr. Samantha.
orthopedic surgeon, normal anatomy and anatomical variants, these two things are very important to know in MRI, because a lot of times the radiologists, they will under-report or over-report. The orthopedic surgeon himself has to know about these things. Very good talk you have given. Thank you.
The best one thing, just one liner for those who have joined in, that the best advantage we are having, that rather than the radiology, is that we are seeing the patient, we are taking the history, and we are clinically examining. 90%, believe me, 90% of the shoulder pathology can be diagnosed only by history and clinics. Rest 10% is given to this your MRI. So don't rely just to see on the MRI. MRI will tell you the 10% of the story. 90% story is from your history and clinics. Thank you.
Samantha sir, one or two questions for you.
Yeah.
So you examine the patient clinically. When you are sending the patient for your scan, MRI scan, what will you write for the note? Will you write for the radiologist?
Yes,
Like
every
you are
time.
suspecting pasta lesion, so would you ask to do scan in some particular position, and similarly for Bankart or slap lesion, something like that?
Yes, because I see, because I am lucky that I am working in a one big corporate hospital. I am working for there for last 20 years. And my radiology guy is a very close friend of mine. Whenever it is done, whenever I send the patient, when I feel that this, sometimes even I do the USG for the shoulder. So whenever I do that, I talk to him. I am sending this name of the patient. This is the finding. And sometimes I go to the console so that we can both discuss, because this is the best way of learning. Because if you want to learn this, it's any joint MRI, please, this is a request, because we have learned very hard ways. This is a request to my all junior friends. Go to the console, talk to the radiology guy. Then only this learning becomes is like a joy. Sergio, we agree on that?
Well, sir, I would speak anyway. See, I absolutely agree on 2 points. The first is 100%, and the second is 95, and I'm going to tell you why. See, I am presenting a lecture, and I am highlighting this in the second slide. As we say in Brazil, clinics is sovereign. Clinics is everything. So it's very important for people to understand that the MRI in the shoulder, in the knee, in the hip, in the hand, it must be interpreted. It's a matter of interpretation based on the clinical scenario. And all of the time, I'm telling my residents, if you don't know clinics, your surgical skills, they are nothing. Okay, so this is extremely important in spine, in hip, in every part of orthopedics. And the second one is, see, the MRI, well, I live in a big city. I have very good MRIs here. So, and the MRI is not an operator dependent exam, like I would say, like the ultrasound. So I generally, I say nothing to when they go to to do MRIs in big labs, but when they come back, if I see something different, then I can call my friends and discuss with them. But this is, I would say, it's very important to have this good relationship with the musculoskeletal radiologist. This is very important. But more important than that is that all of the MRI findings, they must be interpreted through the clinical scenario.
Yes.
This is so elemental, but these young boys, they must understand that without this, you have nothing.
Because we don't operate on the MRIs, we operate on the patient.
And we don't operate on the X-rays too, sir.
Yeah, that is the point I am going to. We don't operate on the films, we operate on the patients. So Girish,
yes, sure.
Girish, welcome. Girish. Girish from Mysore. He is a big shot in Mysore. Girish, welcome.
Oh, thank you, sir. Thank you.
Samantha?
Yes.
Samantha, in India, the patients come sometimes after 4 months of injury. 4 months back, they will take a MRI, comes to you with a rotator cuff tear, suppose. Will you take another MRI to know about the retraction of the cuff or fatty infiltration or atrophy, or do you go for the ultrasound?
So Sergio is already pointed his finger. Sergio is just pointed, then I will answer.
See, this is a very good question, and I was telling this to a patient today in the office in the morning. Okay, the MRI is nothing but a photography of a part of the human body in a moment in timeline. So as we know that the rotator cuff disease is dynamical, is not statical, you see, when a lot of time passes, it would be very interesting to do a new exam to see if the tendon is more retracted and if the Goutalier is I would say,
Three, two,
worse.
three.
So
What gray zone?
how
Gray
much
zone.
can I wait? So this is a question that I have been asking myself for many years. So the number I give to myself, this is anecdotal, but it works in my hands. It works in my practice. The number I tolerate is 4 months. So if we are, I would say, in April and the MRI is for December, okay, I still accept. But if it's 6 months and then I say, well, I need a new one to see if things have changed too much. It's anecdotal, it's a matter of feeling, but it works tremendously in my hands. But the thing is, it could be complemented by an ultrasound, but this is another discussion. I knew that we would have it. I don't like ultrasounds, but it's something that can be done. But this number is anecdotal. For me, it works too much.
Yes, I completely agree with Sergio. Yes, Vivek is pointing. Yeah, Vivek, you're muted. You are muted. You are muted. Muted.
Yeah. You see, I would not repeat an MRI based on mine and anybody else's whims. I think we should repeat an MRI on only very certain conditions, because each investigation comes with a financial implication, and as well as MRI is not an easy investigation. There's a lot of claustrophobia. So I would repeat the MRI if I have one doubt on the diagnosis, the primary diagnosis. If the MRI, let's say, shows a labral tear, a Hill-Sachs lesion, is repeatedly dislocating, then repeating an MRI is not going to give me anything new unless there's a change in the symptom. Number one. Number two, if the period is really long enough, let's say MRI was done 2 years back. Now, I don't expect any major changes happening even in the cuff in 4 months, 5 months, 6 months. Fine, it would have retracted a bit here and there. Okay. Certain situation, I would agree that you can actually supplement with the ultrasound, rather than sending him for an MRI. So MRI or CT scan should always be repeated only when you have a doubt on the primary diagnosis. If you feel that the findings would have definitely changed based on some kind of a material or a literature, which is proving that it does changes. I don't think anything changes within 4, 5, sometimes 6 months. But the development of a new symptom should prompt you to do a investigation.
So I think we should move ahead. Otherwise we'll be time constant, Neeraj. So I think who is going to give? Yes.
Can I make just a small?
Okay.
I went very small. I tried to find this information 6 months ago, which is what is the velocity of the progression of the tear in timeline. There are people studying this in United States, and they are saying something like in 1 year, a lesion can get up to 40% larger in a period of 1 year. So this is something that we know that the disease is not statical, it's dynamical. So how fast does the tear gets bigger? We don't know. We are trying to know. But the thing is, I pardon to differ from Vivek. In 1 year, a small tear can become a much bigger tear, and then the fatty degeneration can get much worse. And from a medical legal point of view, you must tell this to the patient.
Last comment to make on this, and then we'll close this topic. See, the partial tears do not progress for years together. We have studied this. Partial tears, if it's something like a pasta tear or a 30%, 40%, 50% articular basal site tear, it won't progress even for 1, 2, 3, 4, 5 years. The small to medium may progress very slowly, but the larger tears, the one which was large to start, may progress. And that too, it will not be like this. If it is 2 centimeter today, in 6 months, it will be 6 centimeter. So it's about a centimeter a year. That's why I said 3, 4 months may not be, but a year or two. So I think we should move on from this point.
Yeah.
Even the intrasubstance tear and the articular surface tear, as Vivek said, I've seen since 5 years, there's no progression.
There's no change. They don't change. Yes.
They don't change.
So shall we move on? Yes. Manish?
Yeah.
Manish is not listening. Okay, then Neeraj, we can move ahead with the second one. Okay, Vivek.
now Dr. Bhamre has a CT scan presentation.
Yeah.
Yeah, so can you just share your screen, please?
Sure.
Dr. Bhavne, good morning.
Very good morning to all of you.
Okay, go ahead.
Yeah, there you go. Can you all see the screen?
Yeah, we can see the screen.
Right. So, very good morning to all of you once again. And let me welcome Dr. Sergio Rowensky and all of you for this wonderful webinar. At the outset, I'd like to thank the IS and the organizers of this wonderful webinar, Cironic. So I'll be speaking on the role of CT scan in shoulder instabilities. And I think the imaging is very critical. And we need to choose the appropriate investigation so that we can choose the appropriate treatment, the surgical plan, and thus the ultimate aim is to prevent the recurrence, if at all we are operating on this particular thing. I'll just quickly, because it's covering up my screen. Yeah, there you go. Right, so careful selection and evaluation of the imaging procedures is therefore essential to identify, characterize, and quantify the lesions. I think the quantification of the lesion is what we are interested in when we talk about CD. Now, we compare plain MRI scan and CT scan, and I think we're not directly comparing two equal modalities here. They have their own different indications, but in general, we know that MRI is good for soft tissue injuries, especially the rotator cuffs, especially the partial tears better seen on MRI. The soft tissue lesions like the slap, the ULSA, the Hegel's, the GLAD lesion, and the cartilage damage as well on a plain MRI scan. When we talk about plain CT scan, obviously it's better for bony lesions like the bone loss, fractures, the Gunnar versions. If you want to size the coracoid, then the CT scan in general. Now, this is one area where a lot of attention has been driven in the last 7 to 10 years. Initially, there was a lot of attention on the soft tissues and the soft tissue lesions, but I think the bony lesions are picked up very well, and that's very important as well. And this is a wonderful study by Chalmers, and it's a recent study in 2019. And they have compared case by case. So it's a case-controlled study. So the same case, they did a CT scan, and the same case, they did an MRI scan. And they found that CT scan is far more superior in terms of measurement. And MRI underestimates the bone loss. In the sagittal view, if you see here, that's the CT scan image, that's an MRI scan image. And if you see respectively the values here, there is 33% of linear bone loss, and percentage-wise it's 44%, but in MRI it is 22 and 33. So there's a big difference here. Even if you see the width, it's of the Hill-Sachs lesion, here and there, you see it's 2 centimeters and 1.7 for MRI scan. So the MRI scan, especially the 3D MRI scan nowadays people are propagating, is an excellent tool. However, this study highlights that there are still certain limitations and we have a long way to go. But very soon, yes, 3D MRI is going to be one of the options, eliminating the radiation of a CT scan. But this study suggests that, yes, it underestimates the bone loss, and CT scan still is a gold standard. Now, there are various studies wherein CT scan is better for bone loss quantification, and these are a few of the studies I have quoted just to back it up. Right, so there's a lot of talk about CT orthography versus MRI scan as well. And CT orthography does show a good amount of soft tissue lesions and has a sensitivity of 82 to 93% with a positive predictive value of almost 93 to 96% with a negative predictive value of 33%. But the specificity is quite low at 33%. So the overall accuracy is 87. But most of the authors and most of these studies, ultimately they summarize and they discuss and they conclude that the soft tissue injury is not sufficiently demonstrated with arthroscopy. And additionally, there are side effects like radiation as compared to ortho MRI, and they still say that the ortho MRI scores better. CT orthography, can you see my whole screen, or am I blocking with these videos here? Can you see the whole screen?
Yes, you can see the whole screen. Yeah.
Okay, it's probably me who is not able to see because of these videos. Right, fine. So this is a CT scan orthography of a 24 years old lad with an anterior inferior shoulder instability. The broad arrow here shows the Hill Sachs. And if you see this asterisk here, that's the labrum, the labral tear here. And that's the malunited glenoid tube fracture. And you can still see some callus as well here. So if you compare MRI orthography with the CT orthography, they have similar results in most of the clinical scenarios. However, now many studies have clearly given a distinction that MRI is superior for visualization of the intra-articular portion of the ligaments, a depiction of the bone marrow changes, cartilage, and the rotator cuff. While CT orthography is best method for assessment of the articular cartilage surface lesions, fractures, bony avulsions like bony Bankards, and the bone loss. Right, so what are the indications of CT scan in shoulder instability? One or more of the risk factors listed below, like fractures, the patient is associated, the x-rays are showing that there is some fractures and you want to know more about the morphology of the fractures. You want to, if on a plain radiograph you see there are bone defects and naturally you want to know more about that. Recurrent shoulder dislocations in young age, long history of instability, a strong positive apprehension test at just few degrees of abduction shows there is some bony cause for instability and you need more information on that. A revision surgery, when you're planning for a revision surgery and when you are trying to assess a bipolar bone loss and you want to do a proper surgical planning, a CT scan can be an adjuvant. Now, what are the extended indications of CT scan? Now, a lot of people may not do this, but a few people do practice that they want to do a preoperative coracoid size assessment. Not that the CT scan is not specifically done for this, it is done for other things as well. And they do instruct their radiologists that, okay, can you give me a size of the coracoid so that I can plan? And also a lot of people do post-Latarjet procedure for the bone graft healing. Locked chronic unreduced dislocations, it can be one area where you can plan for a CT adjuvant, and obviously the glenoid version. Now, this is a case where there is a small dysplastic glenoid and you see the version is quite excessive. We all know that the normal version is 2 degrees anteversion to almost 9 degrees retroversion. And how does this retroversion, or sorry, how does this version affect instability? Now, a version of greater than 15 in a neutral position has been linked to an increased risk of chronic anterior or shoulder instability. But this is in chronic cases, mind you. If you have a first-time dislocated and you find a person with a lot of retroversion, and that does not mean that they are having a high risk for dislocation. Now, I do a CT most of the times, always rather, anterior or posterior unreduced lock dislocation for a whole period of time. And I would rather plan it properly. I want to know about the soft tissues. I want to know about the bone so that I can plan and go in and maybe try to do as one-stage procedure as much of things as possible. So a CT scan comes in very handy, very important. Now, as I said, a lot of attention has gone to bone loss, which wasn't the case 10 years back. And there was a lot of focus on the soft tissues, and now the focus has equally been given to, rightly and aptly given to the bone loss as well. So acute anterior shoulder dislocations are associated with glenoid, humeral, or both bone loss, and recognition and assessment preoperatively is very important for planning of the treatment, and thus ultimately our aim is to reduce the chance of recurrence after surgery. In the last few years, as rightly said, has been aptly addressed. Now, if you see just the isolated glenoid defects in a first-time dislocator, it is almost as high as 22%. And if you see in a chronic instability, repeated dislocations, it can be as high as 90%. I'm talking about just isolated glenoid defects. Now, if you see the humeral defects, the literature, the various studies suggest for the first-time dislocator, right, from 26.7% to almost 70%. And if you see the recurrent dislocators, it is 87.5 to almost 93%. So it's quite high, even in first-time dislocators. Right, so the bone loss can be bipolar, and it can be up to 89% in recurrent shoulder dislocations. And hence, the quantifying bone loss is very, very important. And it is also seen in posterior shoulder dislocations. Recurrent traumatic posterior shoulder instability has shown 93% of them have some bone loss. as compared to 60 to 73% of the patients without posterior instability after first dislocation. Right, so plain CT scan with a 3D reconstruction is what is recommended as a best option for bony defects, especially in recurrent shoulder dislocation. Now, ideally, you should be doing a 3D reconstruction, and most important for the younger, the new surgeons, I think you have to clearly inform your radiologists that I need a 3D reconstruction. However, I need digital subtraction images of the glenoid and also of the humerus, and that's the way they're going to quantify the bone loss. Now, there is a classification on CT scan to address the glenoid defects. Bigliani has given one, Edwards, and the Griffith, which is classifies into type 3. That is the first one is the classic bony Bankart's. The type 2 is the straight pier with 5 to 15% of bone loss, and inverted pier is the classic Burkhardt. He prescribes the further line of management, which you want to speak further. Right, so what are the methods to quantify glenoid bone loss? Now, there are various methods discussed in the literature. The linear or the Bankart length measurement, the ratio method, the circular best fit or true circle method, the superimposed circle method, or the PICO method. Now, as I said, the most important thing is we want an end-face view, whether it is two-dimensional CT scan or three-dimensional CT scan. If you want to assess and quantify, then we need an end-face view of the glenoid. Now, this is the glenoid ratio method. What we do here is we draw a circle in the lower two-thirds of the glenoid. Take the radius on the normal side, which is the where the bone is, there's no bone loss, especially the inferior. And then you draw another line from the center to the area where there is bone loss. And naturally, from the tip ahead till the circle is the bone loss. So the formula is the small d, the bone loss affected area, and divided by the radius. Now, the surface area method, this is one example in a 25 years old lad. On 3D, you see the A area here is the normal area, and the A2, which is missing here. And the formula is the area which is unaffected and the area which is affected. So the area A2 non-affected divided by the area affected into 100, that gives the formula for a surface area method. The PICO method can be done on 2D CT scan or two-dimensional CT scan, and can also be done on three-dimensional. This is one method where you can quantify on two-dimensional method. We'll come to the 3D, which is far superior, but gives better accuracy as compared to 2D. But it is still possible to do it on 2D. Right, so we draw a circle, and we draw the missing area, that is A, and that's the measurement B, which is from the center to the unaffected area. And that's the one in the anterior part, the A, which is missing. So we again draw a circle at the inferior two-third, and the missing area is estimated. And then the width measurements perpendicular to the vertical axis are measured. It can be compared with the opposite side, however, it is not always required. And we can estimate the percentage of bone loss by the formula of dividing the unaffected part by the one which is lost. So the B divided by A into 100 is the percentage. Now, which is the best method? Now, when we talk about the width method, the glenoid index is the most accurate and reliable. However, it needs bilateral CT scan. In the area method, the PICO method is the most accurate and reliable. And we need not have a bilateral CT scan. It can be also done on a unilateral CT scan. However, if you do it and compare with the normal side, if you have one, then it gives you more accuracy. Now, significance, what is the significance of this in your day-to-day practice? Now, we know the normal glenoid width is 24 to 28 mm, and even a 5% loss means just 1.5 to 1.7 mm will give you a 5% loss. So just a 6 mm loss of glenoid is equivalent to 20 to 25%, which is a critical value. And the glenoid tract we're going to talk about is 18.4 plus minus 2.5 mm. The recurrence rate based on this glenoid bone loss, if it is more than 25%, various authors have quoted the incidence of recurrence rate as 6 to 67% and as high as 75 to 89%. So the relationship between percentage of glenoid bone loss and the choice of surgery. Although there is no consensus as such as to whether it is 20 or 25%, but most of the authors would agree that it is 20 to 25% of the total glenoid bone surface bone loss, and that is a critical value. Now, soft tissue surgeries is going to fail if you have so much of bone loss, and there is a necessity or an indication for a bone graft procedure. Now, if we'll come from the glenoid, now we'll come to the humeral head defects. Now, 3D CT scan is considered as gold standard for humeral head defects. Hill-Sachs lesion for the beginners is, just to tell you, that that is on the posterior superior part. However, the bare area is the posterolateral part, so one should not confuse in these two areas. Now, what are the quantifiers in the CT scan? Now, if you see the CT scan, the size, that is the length and the width, and the orientation of the Hill-Sachs. That is very important. Now, you see these two figures in the lower part. Now, see this orientation. One is vertical and almost parallel to the long axis of the humerus. The other is oblique to the long axis. And this is important, and we are going to discuss it further. The humeral head, we can have the arc, that is loss for the Hill-Sachs, or the depth of the Hill-Sachs, again, can be calculated on a CT scan. Now, the lesion orientation I was speaking about is very important. The moment you see a CT scan, a 3D CT scan, and you see a Hill-Sachs lesion and you see the orientation. Now in the first picture, you see that the orientation of, that's the humerus, and the orientation of the Hill-Sachs is like that. So the moment you go into abduction and external rotation, it becomes parallel to the glenoid. And the moment it becomes parallel to the glenoid, it can engage in that particular position. However, to start with, if it is vertical, that's the humerus. If it is vertical and you go into abduction, then the angle, the orientation would change, and it has a less chance of getting engaged. Now, this is a CT just to show you a bilateral engaging Hill-Sachs with a very deep Hill-Sachs and an engaging Hill-Sachs. Right. So,
Dr. Dharampal.
Yeah. Tell me. Hello.
Hello, Dr.
Yes,
Dharampal.
Yeah.
Yes, so we need to move a bit faster. There are other lectures pending.
Yes,
so
yes,
sorry for interrupting.
Certainly,
Yeah,
certainly, right. So Flato et al. Says that if you have, they classify into less than 20, 20 to 40, and more than 40. If you have a bone loss of more than 20, just if it's less than 20, remflicide is good enough. If it's more than 40, then we need a bone graft. But we also need to see the depth, the volume, and the other factors as well. Right, so I think I'll quickly move on to last couple of 3-4 slides. A normal glenoid tract is starts from the articular surface from where the rotator cuff is to an area which is around 83% of the glenoid. And this is area anterior to this blue area is the tract which is normal. So this is the only area where the normal glenoid, the humeral head would move, and it doesn't dislocate in a normal circumstance. So this is the 83%. This is the glenoid tract, the inner margin of the glenoid tract. Now, an on-track lesion is the one wherein the Hill-Sachs lesion is smaller than the glenoid tract, and hence there is a lot of bone here still before it dislocates. So it is on track, and it is on the track of the normal glenoid tract and the Hill-Sachs lesion, and not extending beyond. So these are more stable and not engaging. Now, off track is the one where the Hill-Sachs lesion is bigger than the glenoid tract. And naturally, this is going to be the one which is going to be unstable and dislocating. And in this case, as you can see, that is the glenoid tract, and the red margin is the one where the Hill-Sachs is extending beyond, or when there is a glenoid loss, that is going to extend beyond. So what is the significance of this? Now, if you have, if this study suggests that 6% out of the 100 cases they studied, an arthroscopic Bankart repairs was done, and in the patients who had an on-track lesion, only 6% had revision rates, while the people who had off-track lesions, the incidence was almost 33%. Now, anterior shoulder instability, here we classify, if the glenoid loss is less than 25 and it's an on-track, recommended is arthroscopic Bankard's repair. If it is less than 20, off-track, an arthroscopic Bankard with Remflissage. These are just general guidelines coming from various studies. If it is equal to or greater than 25% on track, Latarjet procedure. But mind you, if it is more than 25% off track, then you need something more along with Latarjet, like a soft tissue, even if you do it open or arthroscopic. Right, so to conclude, the labral ligament and capsule complex injuries are better detected on an MRI scan, and MRI still remains a gold standard. However, bone defects, quantifying this bone defect, identifying them, CT scan is still a gold standard. MRI orthography versus CT orthography offer distinct advantages, what we saw, but they are restricted to chronic instabilities. In an acute case, you will still do an X-ray and maybe an MRI scan. And if you want to really go for a recurrent case, a revision case, and you want to do a surgical planning, I think that is where a CT scan would definitely play a role. And for bone loss, CT scan is still the best. Thank you indeed. Thank you for your patient listening.
Thank you, Dr. Dharampal. It was really an excellent presentation. Can we have a few questions, if anyone?
So, Dr. Dharampal.
Hello.
Yeah, hello.
Yeah, Dr. Bamre, this is Dr. Vivek here.
Oh, yes, Dr. Vivek, tell me.
Yeah. So could you just say, let's say summarize. So if you have a patient who comes with recurrent dislocation of the right shoulder or any shoulder, what is the first investigation of choice?
Right. I think this is very important, especially for the junior.
Because this remains debatable. You know, some people say MRI, some people say CT, but what is the overall consensus appearing across the country?
Right. So basically, for any case which comes to you, the clinical examination still remains very important, followed by the X-rays. That's the baseline. Now, whether you want to choose, I think if you see the literature doesn't debate on whether MRI, if you just want to do a one investigation, whether it's just MRI or a CT scan, it debates on the advantages of MRI and the advantages of CT scan. So you'll have to choose your patient, what you really want. For example, if
what is your choice? That's why I asked you.
First line,
your choice?
Yeah, my personal choice would be an MRI scan, preferably a 1.5 to 3 Tesla, to be reported by musculoskeletal radiologist. I would also love to see the films myself, and I have a good rapport with the radiologist, and I would always want to give them a feedback. So this, yes. But if as I said, you know, there are indications where I want to know more about the bone morphology, and there are fractures associated. It's a revision case. It is recurrent dislocation in a young patient. Well, I would adjoin that with a CT scan. So it's not that I would be replacing a CT scan and MRI is the one. So the debate is not to choose between one. Wherever required, it has to be adjoined. So a CT scan would be an adjoint to an MRI scan. Yes. So in most of my practice, I would order both, honestly.
Yes, Sergio, you wanted to say something?
No, I just want to say something. I absolutely agree with Dr. Dhamapal. I have already had this discussion here in the United States a couple of times. There is, besides from the medical point of view, we still have to forget the costs of the two exams. So two exams, they cost more in the pocket of the patient. This is something not to be forgotten. But I fully agree with Vivek. So in the ordinary patient in the office, if I have to choose for one or the other, is the MRI. I do it in the office very frequently. And if I don't have the information that I need on the MRI, then I will ask on a second moment for a CT. I guess Vivek thinks exactly like me. Yeah, Vivek.
I here I a bit disagree, because we all, I think, India and Brazil in certain senses are same. So for me, my primary investigation after the clinical examination, when I'm sure that it's by and large we are dealing with a primary anteroinferior instability, and I don't have a doubt of, let's say, the posterolateral repair or the superior tear, then I will go for CT scan. Because in a classic traumatic dislocation, whether it is whatever way, I know that by and large, there is going to be anteroinferior lesion and there's going to be the Hill-Sachs lesion. An MRI, if I have very little, clinical suspicion of posterolateral tear or a slap tear, I'm not going to get any additional information unless, let's say, I have a doubt, is there any associated cuff tear, anything else I'm missing? So my primary is always CT. We always do CT. And 99% of the time I proceed after the CT. But if I have a doubt that is there a slap tear, is there a posterolateral tear, is there some issue of cuff, like patient has developed off late some pain, he says now it's painful, because in a classic recurrent dislocator is never painful once the episode subsides. But if there's a new symptoms developing, then I'll say no, now this needs more investigation. But as Dr. Bamre said, I fully agree. Which is the best, it's always the choice. So given a choice on a day, I would love to have both, but the choices are not always there. It's always the dollars.
I know. I was just mentioning the costs, but there is just one more thing. The medical decision is always the most important thing, but there is just something that I want to highlight. From a medical legal point of view, the MRI can literally tell you there is a Bankart lesion, and on the CT, you don't have this information. So from a medical legal point of view, this is not the most important aspect, but it's something to be thought. From a medical legal point of view, the MRI will protect you as a doctor more than a CT. Do you agree with that?
I agree with this. It's actually now these days, it's more than medical legal. It is the insurance companies who want the prior, confirmation of the lesion. And then they say, okay, the case is approved. So that's why in some centers in India, like in Pune and Mumbai, what they're doing primarily MRI, but they're doing the complementary CT cuts with very minimal charges. Okay, so the patient is not now actually paying too much. So that's a one good thing which we can evolve across the country.
Manish is waiting to say something.
Vivek, I think we need to cut short the discussion and time for your lecture. We are already late on the schedule. Okay, sorry, Sergio.
Okay, sir.
Yes, Girish is telling something.
Are always very good. These discussions are always very good.
Girish has to unmute. Girish, you have to put the space bar. Girish is muted. Girish, you are muted.
Hi. So regarding, as Dr. Vivek said, the insurance guys, these are the people who make these things complicated, even though we are sure about the dislocations, the kind of dislocation, but the insurance, they want the MRI to be done. And also what I've seen in first few dislocators, there won't be any much of bony lesions. Whereas in a chronic dislocators like recurrent dislocation, there are more amount of this bony dislocation. At that point, I usually go for a 3D CT scan.
Okay, good.
Okay, so shall I start, Manish?
Yes, please. Yeah, go ahead.
Okay, so good morning, everybody. So I think Dr. Swanendu and Dr. Bamre has made the life easy, so I don't have to talk anything about the investigations which are primarily done in the instability patient with instability. I'll straight away go ahead with a selected case where we are planning the arthroscopic instability repair. What are the typical indications? I'll not go again into the debates, but these are the typical indications. These are usually the primary dislocators without any major bone loss, or a recurrent dislocator with a glenoid bone loss, usually less than 20%. Sometimes you can say, according to Itoy, you can say, okay, 25%. With the on-track Hill-Sachs lesion. If the Hill-Sachs is off-track, some people now these days, they say you do Letarge, but I still practice along with the remplissage. And a repairable bony Bankart with a fresh viable fragment. So these remain our typical, instability repair cases. Position, in which position we do? Yes, people do it in beach chair and people do it in lateral, but over the years, the consensus is emerging that doing an instability in a lateral position is much more easier, and doing the cuff probably in the beach chair is much more easier. In some company systems, you have a lateral traction is anyway there. There is a system by which you can give a the distraction, you can actually distract the joint superiorly, and that makes the life very easy. Now I'll just summarize few steps and I'll come back again to these steps later. So once you have, made the, position and the portal is made, the first thing in the instability is always probe the lesion all around and establish the additional portals if required. First, you always finish the slab tier, then you finish the posterolateral tier, and this I'm talking of the situations when there is a the global tier. If there is a remplissage which has to be done, always place the anchor, take the bite, but do not suture, because if you suture, your posterior space decreases, the maneuverability between during the shoulder surgery becomes difficult. Now, from there, you focus onto the anterior lesion, you do the adequate release, you extend the lesion by half to 1 o'clock if required, prepare the glenoid margins using the curette or burr. You place the anchors, usually 3, rarely we have to place 4 anchors, but that's not very common. Then you take the adequate tissue bites for IGHL and the capsular tensioning. In case if you encounter that the tissue quality appears to be poor, but anyway you have decided to go ahead with the repair, then you can place either the matrix sutures or the Mason Allen type of sutures or a lasso loop. All these techniques I will show during the talk. The 9th one remains a bit controversial. Some people practice across the country and abroad also, like Sugaya, myself, Ashish. If you do the sequential tying, means you tie from the top and then you go below, you can actually give some kind of a little bit extra shift. I call it as a south to north shift. And lastly, you finish the remplissage. So let's start. The portals. The portals are the key. An idea of all the portals, not only that I know how to do bank card, which I learned in the last workshop. In fact, you need to know all the portals, which all you need to establish for all kind of labral tier, because the panlabral lesions are not uncommon. If you have a typical antero-inferior lesion, then you go ahead with the antero-inferior portal and antero-superior portal. So this is where the antero-inferior portal is, just in the lateral half of the subscap. So this is the subscap. You place it just in the lateral half. The antero-superior portal, which is my usually vision portal, it is just next to the biceps. Some people also make it on this side of the biceps. It's up to the surgeon. So during the entire talk, I will keep my scope in the antero-superior portal, and my working portal are the standard posterior portal and the standard antero-inferior portal. These are the 3 portals which are made for the classic bank card repair only antero-inferior. But really, you must understand that once you put the probe, the global probing should be done. Probe all around. Look at this. There is also a posterolabral tier. Okay, posterior-inferior. So probe the labrum all around 360 degree to assess the damage, because often, not very rarely, often you can actually miss the posterolabral tier on an MRI, because the sensitivity and the specificity of the MRI for posterolabral tier is not very great. Look always for the slab tier and posterolabral tier, which are not uncommon. Now look at this. Here we have a patient who has got the large Hill sacks. Look at this. There is a superior labral tier, which is quite complicated. And then we also have a anterior labral tier, inferior labral tier, and a big posterior labral tier. You see this? Now the scope is in the antero-superior portal. Look at this. This is anterior. This is posterior part. This is anterior part. There's an anterior labral tier, there's an inferior labral tier, and there's a posterolabral tier. So you may land up actually sometime in this situation, and you can't come out saying that I know only how to repair the anterior labral tier. You have to repair everything. So in such situations, the best is to start repairing the slab first, then you do the posterolabral repair, then you do the remplissage repair, and then you do the anterior-inferior labral repair. I'll tell you why. And repair of these additional lesions is essential for a superior outcome. Now, why you can do the slab when you are in the posterior portal, but why posterolabrum first? Because if you have already placed your sutures for the remplissage like this, and then negotiating your sutures for the posterolabrum, which will be coming like this, it will look like a Spider-Man's cobweb, and you'll be thoroughly confused. The best way is to actually finish on the posterolabral tier, tie everything, and then you are left only with these sutures of the remplissage. Now, the slab tier, you can finish it off when you are there in the posterior portal by place the anchors via the classic slab portal. I'm not going into detail of repair, but just I'm showing the portals. And bites, you can take it from either from the antro-inferior portal or the Navier portal, which will be somewhere here. So you can take the bites from here. Okay, these two can be done to finish these slab here. Posterolabral tear, if there is an additional, so finish the slab, go to the posterolabral tear, and ensure that you placed your this is how it is done, which is also known as a port of Wilmington. It is just on the posterolateral corner of the acromion. Now, so you have finished the slab, you finish the posterolabral tear, and then you go to the remplissage. It could be also done sometimes through the 7 o'clock portal. Otherwise, you have to establish just a little lateral to the standard posterior portal, a portal which goes bang onto the Hill Sachs area. This is how you place it, and then I'll show in my video how it is done. So, so what are the key steps of the instability? Probe the lesion. Again, this is the same thing. I'll just put up this slide here. So this is my short video on a classic Bankart repair. Now this is a left shoulder. Patient is in lateral position and he's undergoing diagnostic arthroscopy. There's a piece of cartilage which is damaged. This patient had about 6% of bone loss. Joint appears to be a bit lax. And this is a kind of an ALPSA lesion. So first you start debriding the lesion. You debride, remove all this, and then you elevate the labrum using the labral elevators, which could be down or it could be up. Sometimes I use the radiofrequency device to extend the lesion. Sometimes I use the scissors to extend the lesion. Now, some of you may raise a concern that I'm close to axillary nerve. Axillary nerve is very far. If you're doing routine arthroplasty and routine shoulder exposure, it's very far. Now here in this case, if you remember, I have extended the lesion by about half a clock. I've gone almost up to the 6 o'clock. Next, you curate the margin using the ring curate, or sometimes you can use the shaver or a burr. A little curating, don't remove too much of cartilage. It's just about 0.5 millimeter or a millimeter of a cartilage, so that when you put back your labrum, it will heal with the bone. So normally what I do is I prepare the whole thing. And then sometimes I go back to the Hill Sachs. Now, since Roshan is not taking his talk, I'll be talking a bit about remplissage, though not in detail. So once I finish my anterior work, then I go to the posterior work. This is the Hill Sachs lesion. This is a special technique which you have developed. I am just ignoring that part anyway. So this is an additional portal. Remember, the portal for remplissage, I have created a separate portal. Then you just clean up this area, remove the little soft tissue, because you have to do the tenodesis of infraspinatus, which is here, to the crater of the Hill Sachs. I usually use single anchor. Sometimes if the lesion is very big, I use two. Choice of anchor could be anything. Since it remains extra-articular, I often use a metal anchor. Sometimes I use a PEEK anchor. And then it's the simplest possible technique. I don't use any fancy technique. 10 years I have done this. No, about not 10 years. I would say about 9 years I have done this. I just take two bites. One is the bite from the center. So you have something like this. This is how the anchor is coming. One suture is pulled from here. One is pulled from here, and remaining two remain here. So this will be tied like this at the end. That's all. So it's the simplest possible technique. No fancy work. Now, once you have done this, we go back to the Bankart and you see how I'm placing the anchor. Usually my inferior anchor is double loaded. At a 6 o'clock position, you see how easily you can reach the 6 o'clock. And why double loaded? You will watch in a moment that why I put a double loaded anchor. All intra-articular anchors are usually the PEEK or bio, or maybe all suture anchors. The first bite what I take is usually from posterior side, and you'll see how and why. So I've removed the 3 of them. So this is a left shoulder, but I'm taking a right suture shuttle, and I grab the inferior labrum and capsule with the help of a suture retriever. This is the most useful thing. Whenever you take a bite, you can always hold it with the suture retriever. And then the first shuttle comes in. And this, when we will tie, what will happen? There's a huge inferior capsular shift. If I put a single, sometimes I'm not very happy. Now, this is a controversial step. Very few people, me, probably Dinsha and some other people use this direct bite, and I've been extremely happy with this. I use simple expressive to take the bite from the inferior one, because the inferior one is the most tricky one. Now, in this case, the one which video you are seeing, I'm going to show only the knotless anchor, the rest two. So I'm going to take 2 bites. So inferior one was the knotted anchor. Now, again, you see, to take the bites, the best tip is to hold with a suture retriever. Just hold the margin, because it has a tendency of swinging. When you do without holding, it tends to swing, and that's very irritating. So this is only the knotless. So I've passed the suture already. I'm taking the, putting the anchor. The first knotless is in. And then it's being tied. You see, initially it was a bad ALPSA lesion, but now you can see a very good bumper. So the key here in any instability, especially anterior instability surgery, is always do a fantastic release. Take your time, 5, 10, 15 minutes, till it is released, till it floats spontaneously to the level of the glenoid. Do not proceed. And you see, this is the inferior most time time. Look at the amount of inferior capsular shift I've got. This is extremely difficult to get with a single anchor, single loaded anchor. Okay. This is how you get a fantastic bumper. I was in doubt, so I put one more knotless on the top. So I have been almost now 9-10 years. I have not changed. I always use 3 anchors in front. Knotted, knotless does not make a difference. Don't get carried away with this video. Okay, you can use what you are comfortable with. Knotted, knotless, everything is fine. Now, once you have completed the Bankart repair, you can shift your focus to the Hill-Sachs lesion. And now if you carefully watch, the space behind has actually reduced. And that's the reason you have to place your anchor beforehand. If you plan at the later part that I want to place your anchor, sometimes it's a bit tricky, because after the Bankart repair, the head tends to centralize and you get very little space behind to place your anchor and take a bite. So this is the complete repair. I'll shift to the next one. Now, sometimes I do additional capsular shift using the north shift. This is what I usually do. Some of those who have been my so I usually hold with the, I'll again show you what I mean with this. So after the liberation, placing all the anchors, so I usually start trying from top, not from below. So I tie from top so that I get a little extra, about 1.5 millimeters of more of the capsular shift. And then I tie the lower part like this. And this is how the completed repair looks like. If you want to, I'll just stop this video for a while. So if you, sometimes in this case, if you see, this is recently done about 4 months back. Now here, what is happening, the labrum is kind of ending here. The labrum is ending here. In that case, if I really want to shift everything, I will put a traction suture at this part, and I'll pull it. So just watch how it is done. So we, release everything. You see the labrum is kind of ending there. So you release, and then you put a traction suture at this place where it is holding with the help of the suture retriever like this. And then once you have prepared the entire margin, you take the bite inferiorly. But before you tie the inferior one, you place the knotless anchor on top. So whenever you have a traction suture and which you want to incorporate later into the Bankart repair, always put a knotless. That's why your armamentarium should always be complete. And then after this, you can go back and tie the lower part of your repair. You see, this is how the entire repair looks like, which was a bit dicey in the beginning. If the tissue quality is poor, you can use a lasso loop, mattress, or a Mason Allen. This is how the mattress technique looks like. So I've already placed it double loaded inferiorly. And this is how, again, you see, whenever I take the bite, I always hold the margin with the suture retriever. because then the margins do not swing. You know, it remains in your complete control. Otherwise, it tends to swing as your suture, the penetrator goes in, it tends to move around and it's very irritating. So I can see the tip. In fact, I can push it like this and I can see the tip of my, you see, this is how I see the tip of my suture passer. So one is done and then the second one is done here. That's it. And then you can tie the mattress. So whenever the tissue quality is poor, you can always tie the mattress because mattress will always give you much more larger area, more compression. And the cheese wire effect with the simple suture is much less. Lasso loop technique, this was developed by the LaForce. You see, this is how the lasso loop technique is done. Here, it is the left shoulder, topmost bite. You use like bird beak or the sixter kind of a device. Pull out one limb and then through the loop of the limb, you see, through the loop of the limb, those who continue to do this lasso loop technique in the rotator cuff and other places will find it extremely easy to understand. Through this loop, you again reinsert the tip and pull out the limb which was intended to be pulled. That's it. It creates a cinch knot. And this is very, very secure, very nice. It avoids all the cheese wire effects. The only thing is after this, you can't tie a sliding knot. So you have to tie the non-sliding knot. So this is how the repair would look like, which was initially a bad ALPSA type of a tear. If the another thing is, if the tissue quality is poor, you can use a Mason-Allen technique. I will just forward it. So here, if you carefully see, it's a double-loaded suture. You see the one pair is mattress in fashion and one pair is still in simple in fashion. So you tie the mattress and you can tie this. So there are many techniques by which you can use if you find that the tissue quality is not really good. And you can use a single anchor to have a larger footprint for the coverage. Whether you want to use a simple suture or all horizontal does not make any difference. In fact, the results are similar. One point of concern, when you put your inferior most anchor, whatever you do, there is some amount of anchor perforation. But even if there's a 60% of anchor which is in contact with the glenoid, it's okay. The pull-out strength does not matter much. But those who are using the all suture anchor, remember all suture drill bit is very long. And here you've got an important structure that is the axillary nerve. So be very cautious when you're using the all suture anchor because you're very close to the axillary nerve, especially if it is the inferior anchor. Chance of perforation of anchor is almost like 50%, and you would never know because you don't do any investigation to see. Now these days we all use the, the peak and bio, which you don't see. What you can do to prevent, have a perfect angle, and sometimes the curved anchor. Now the curved anchors are coming more and more, so maybe that's one way. But over the years we have used, even if there's a perforation, I have seen some of my post-op CTs done for some reason. We have seen the perforation, but it's okay. It does not make a difference. How many anchors you need to put anteriorly? Lot of debate, but today, as of today, what they say, three anchors. Okay, if you're still short, you can use double strand, double loaded, and at least each one you can put, mattress bites, so you get many bites. You can actually create 1, 2, 3, 4, 6, 8 bites with 2 anchors also. Only problem is everything bunches up together. Okay, but try to create more bites. Remplissage or no, we have just recently published almost like our 8-year-long study. Remplissage does reduces the incidence of redislocation both in on-track and off-track both. This was a publication in JSCS. Is knotted better than knotless? No difference. Use what you are best at. But inferior one, I would still say you can use a knotted one because you get more options to do the things. Should you close the rotator interval? Only in probably MDI cases, and MDI everybody operates very little, so routine closure of rotator interval is not required. Should I close the PI-EGHL because the AI-GHL and PI-GHL are considered to be a kind of a hammock? Some people do, some people don't do. I have never done it routinely. I've done only when I feel that there was some kind of a laxity and bitance was something like more than 6, then I would do this. Otherwise, routine PI-GHL plication I don't do. Should I use cannula or cannula-less? Something like your Sugai does not do what you do best. Don't struggle in the surgery. Thank you so much. Thank you very much. Hello.
Thank you, Vivek.
Thank you, Vivek.
Nice one, elaborate one. We have basically seen all permutation and combination of the Bankart repair.
Yeah, everybody can now start their video. So there is one question from Tanmay Chaudhary from Indore.
Yeah, Tanmay.
For Vivek.
Yes.
Yeah.
What is the percentage of, can you hear me, Dr. Vivek?
Yeah, I can hear you. Yeah.
Yeah. So what is the percentage of cases in which slap repair is required?
Maybe 10 years back it was 20%. Now it is less than 1%. Because remember, slap.
So even if you
need to
see a
have
slap lesion, the
100%
slap repair may not be needed.
No, it's not that. You see, one is you need to have 100% clinical diagnosis. Like you should have a clarity before you operate that there is a doubt of slap tear, pain, inability to throw. But remember, inability to throw is also a part of the recurrent dislocation. Second, the MRI must, in the cases of instability where you suspect that there is a slap tear, do not proceed unless you have an MRI. Let it get confirmed by MRI and then you do arthroscopy. So slap is clinical, MRI and arthroscopy. Okay, it is better to lesser do rather than overdoing, because these patients, if they become stiff, there is no way out. You have to go back again. So it's very less now, probably less than 1%. Yes, Samantha sir.
I completely agree with Vivek, and this is probably the message from this room, that this is very, as such, this is a rare possibility. You have to diagnose with the MRI, and if you tighten the slab, the patients become more painful. Sergio, your opinion on that?
Well, see, as I understood, because my audio was not so good, it's good now. Can you make the question again, sir?
Question is what is the really your clinical practice? What is the real percentage of associated slap with the Bankart? And if you see that, what is the percentage do you repair, and how you do it?
It's very, in my practice, is very infrequent, very uncommon. And if I see it, I will fix it in the very upper part, but I have to take a lot of care not, so to say, to extrangulate the root of the biceps. I guess you were mentioning that.
Yes.
Because if you do like this and you struggle the root of the long head of the biceps with the inferior anchor and the other anchor, it can generate a lot of pain.
Yes,
so you must take care with that. I guess Vivek and you agree with me, sir.
Vivek.
The thing is, the classic Snyder's type 2 slap hardly actually is there. Most of the time it is the posterior superior. So you can, if you are still tempted to do that, you place your ankles a bit away and the bites a bit away from the root of the bicep. So the root of the bicep should remain flexible, because even if in the routine arthroscopy you probe it, see, it's a very flexible structure. If you convert a flexible mobile structure into a rigid non-mobile structure, it is going to create trouble. Very serious trouble.
Pain.
One, two.
A lot of pain.
If you still have to do something for superior labor, and when patient is over 30, 35, it is better to inform him pre-op and do the biceps tenodesis. Don't do anything there, because they will do you.
Sir, just one thing. I'm not going to be getting into this long discussion because of a matter of time. I am a biceps killer for a million reasons, but the thing is, whenever you have a doubt, don't hesitate in killing the biceps doing tenodesis, because as I have mentioned so many times, I have discussed this with Vivek in person a lot of times, you can always regret of not killing a biceps, but you will never regret of killing a biceps. I say this to my shoulder fellows all of the time. So I fully agree with Vivek. In doubt, kill it, do a tenodesis, and you will be happy forever.
The only problem in the cases of, when you are talking about cuff, okay, kill it. When you're talking about instability, one thing we should not forget, that biceps is supposed to be one of the stabilizers of the shoulder. So theoretically, if you just kill and leave, one, you are leaving a purpura deformity in a young patient, and two, you are kind of removing a superior stabilizer. Okay, superior and external rotation stabilizer, because biceps functions best when it is in external rotation and abduction. So perhaps if you still want to do something, okay, you cut it, but do the tenodesis. That's what probably the message should be.
Yes.
Vivek, Vivek,
Yeah.
so you have mentioned 3 or 4 types of suture. Do we have any literature evidence supporting which is better? I mean to say simple, mattress and the lasso. I think these are the 3 you have
Not
mentioned.
really, but I think Denny Lee, if you listen Denny Lee in many conferences, Denny Lee has done some cadaveric study. I'm not very sure whether it is published or not, but he said he had some failures in his cases. So he started doing Mason Allen. So, but otherwise, if you listen to everybody world over, not everybody is particular about, but I think it's like, case to case you can change. If you find that a capsule is not very good, you can use either the lasso, mattress, or Mason Allen. But the routine, juicy, good, thick capsulolabral complex, I think Simple does. But Denny Lee can answer this. I have heard him many times saying this. Like he now does routinely Mason Allen.
So I
Okay.
think the message,
And what
message, for the, message for the people, those who are viewing this and from this forum, that most of the time, unless it is a very recurrent dislocation like 10, 20 times, your tissue is good.
Yes.
If you find the good tissue is there, you can recreate the bump. That is the basic idea. If you can recreate the bump, then your simple suture is very, very good for
Yes.
your Bankart. You don't have to struggle with this lasso or the Masonella and whatever. Make the
Correct.
surgery should be simple. And one liner for the slap is that if you want to put some suture around the slab with the Bankart, please tie the knot on the back side of not in the front side, because if you do that, it will be more painful.
Agree. I think we should proceed from here.
Okay, so Samantha sir, should we finish this session? I think Anup is there to say something, or you have something more
Now
to say?
Sergio is going to talk. Anup
Okay,
will
okay. My mistake.
Before
Sergio, please.
before Sergio, Anup will want to speak for 2 minutes.
No, I think Anup, Sergio should, because he is already late in the night. Okay, so
No. Sir, I am absolutely free. If Mr. Anup wants to talk, that's lovely.
This is the routine time for Sergio to sleep. 2, 3, 4.
No.
Yeah. So Anup, you want to share some slides?
One question, sir, Swanendo and Sergio.
Yes.
Swanendo.
Yes.
So according to literature, in first-time dislocators, hello?
Yes,
Anup, go on.
Yeah, in first-time dislocators, the ill-sacs percentage of ill-sacs is around 20 to 70%. Do we need to take a CT with the MRI in the first-time dislocators?
No, every time for the first time dislocator, unless you are seeing something like a bony fragment, big defect in the humeral head, you don't go with the CT. Because when you go with your scope inside, you follow the Burkhart's line. It is very beautifully written that whether it is parallel or oblique, and it's not deep. If it is not parallel and it's oblique, it's not very deep in the MR, and if you feel it is not engaging type, then don't go with the repair or the remplissage on the first go. Agreed, Sergio?
Yes, sure. Sure, sir. You see, I just want to highlight one thing very fast. To be very honest, Vivek is a super surgeon. He can manage all of these lasso sutures with a lot of facility. But for the youngers and the beginners, I fully agree with you, sir. Simple sutures, as long as you do the inferior bump and tension the anterior glenohumeral ligament and do the job, then spend time and fighting with difficult sutures. I guess that everybody will say.
You saw me using the double loaded, and my inferior most comes using the suture, passer.
Yes,
which I
never got
use the portal. And
okay.
The routine. This is the single most intention.
Yeah.
Because I completely that is the stage. Yeah.
Anup, go ahead.
Yeah. Dr. Neeraj, am I audible?
Yeah.
Great. Good afternoon, everyone. Thanks the organizers and the faculty on this call and the delegates for this very short time for us to speak a bit. I'll keep it as short as 4 to 5 minutes, couple of minutes to kind of introduce Healthium as well as Seronics for the larger group. And then what are we doing for COVID and the support that we're trying to extend. Given the fact that everyone is locked down and the HCPs are still fighting it out and trying to help the citizens at large, we're very, very proud to be associated in our own way, being an Indian company deeply rooted in India. Just to quickly say, Healthium is a company that started from India, now has about presence, direct operations in about 3 countries with 3 different companies, and spread its wings across 70 countries across the world. Our products not only from wound closure and urology and consumables to endosurgery to arthroscopy solutions. What we've been doing, just like many responsible companies have tried to do in their home countries, and we've tried to do our bit, in India, is we've already donated about 82 lakhs for the Prime Minister's Care Fund, and also about 70 lakhs worth of essential medical consumables to various government institutions across the country. Not only this particular contribution, we've also tried to create an impact and spread awareness around the communities wherever we are operating from. We've not only distributed in multiple villages, the self-protection kits like gloves and face masks and sanitizers, but also for daily wage workers who've gotten affected, 1 month's free supply of groceries. While currently we're following the norms and we're working at about 25-30% workforce, the whole 3,000, close to 3,000 employees that we have, all of them, including the daily contract labor, all have been taken care by us until now, and even till the lockdown finishes. Very quickly, last 1-2 slides about Seronics. Most doctors who are working with us kind of know this. It's a completely Indian designed and manufactured product range from Seronics. We have 40 plus patents, both US and Indian, each product already commercialized with its own USP. What we are committing, apart from what we have done at a group level, is we would want to extend 500 free knee surgeries once the lockdown is finished in the key red zone states. Most of these surgeries would be routed through teaching institutions and government hospitals in those states where affected daily wage workers need to be assisted. And we're taking that front step in kind of extending our support from a knee surgery perspective. And there are a lot of local level support that we've also planned. The whole team at Seronics will reach out to the doctors and participate wherever we can to kind of help everyone kind of tide over this massive disruption caused by COVID. Broadly, that was the announcement that we wanted to make. While this is the contribution and the help that we're extending till date, this will continue to happen until all of us feel totally safe in continuing with our lives as it was earlier before this hit us. Thank you for your time. All of you stay safe, and we'll see you very soon, hopefully in your clinics.
Thank you, Anup.
Fantastic gesture.
Thank you. Okay, move ahead.
I think Sergio can start his presentation.
Yeah, Sagru.
Sergio can start his presentation.
Yes, all set. All set.
Yeah. Just a second. So, sir, hello.
We can hear you.
Sergio, go ahead.
Yeah.
So, sir, can you hear me?
Yes.
Okay, and is my presentation on?
Yes, it is on. It is on. You can go ahead. It can be. We can see it.
Okay, lovely. So, see, it's a pleasure for me to be here. I'm gonna talk about something that I think is very important in any rotator cuff or arthroscopy, which is the role of being aware of knowing how to look to the subscap and biceps lesions whenever needed, because this is something that came to my mind a few years ago. I started to see these things in the office. I started to study this, and it makes a lot of sense. And this is, I would say, supported by literature. So this is what I want to talk now. I want to talk about the diagnostic role of arthroscopy in a cuff repair. Okay, so for start, So why do we indicate a cuff repair? When do we do this? As Dr. Samantha was telling us, everything depends on clinics, of course. So we have a clinical scenario of typical subacromial pain, which involves classically shoulder anterolateral pain, which involves shoulder pain to sleep, which involves shoulder pain to elevate his arm in near's arch, which involve pain that gets worse with motion, and of course a proper physical examination. So with all of this clinical scenario, then you will ask for an MRI. But what we must understand, as Dr. Samantha was telling, and I say this to my residents every day, and I will keep on saying this until the very end of my life, is this. This is what we say here in Portuguese. A clínica é soberana. Clinics is sovereign. And clinics is everything. And I find a beautiful joke about it in the internet 2 days ago. So see, we use a lot of buses here in Brazil for people to go to work for public transportation, and see this. In every bus in this country, there is this phrase, this is a law from the federal government, which says, talk to the driver only what is indispensable, only what is essential. And this is the joke. So what will you tell him? That you will tell him that clinics is sovereign. This is the only thing you must say. So this is a beautiful way of saying that without clinics, we have nothing. But anyway, when you have the clinical scenario and you will ask for an MRI, this is something that I want to make the beginners understand. How capable is the MRI in showing us the existence of a posterior superior cuff tear? The answer is the ability of the MRI to show us a posterior superior tear is very big. So the sensitivity, the specificity. So in this sense, first of all, so what is the posterior superior cuff? The posterior superior cuff is the anterior and posterior part of the infra and the anterior and posterior part of the supra. All of these cases are my cases, personal cases that I have already operated. So see, what is the capacity of the MRI to show such a tear, a gigantic tear, a big tear of the posterior superior cuff? Well, it's 100%. In the same way, what is the chance of an MRI to show us a medium-sized tear? I would say it's 100%. And in a big tear, irreparable tear is 100%. But even in small, complete tears, the sensibility and the sensitivity and specificity, they are very high. And even with pasta lesions, with partial articulate-sided tendon avulsions, like these ones, the MRI has a very big, I would say, capacity to show us all of these lesions. So this is another pasta lesion. This is another lesion, which is some people call it reverse pasta, and others call it bursal-sided partial tears. Okay, but in all of these tears, the ability, I would say, the capacity of the MRI to show us the tear is very, very, very big. This is another bursal-sided tear, and this is an intrasubstantial tear. But independently of the pattern, in all of the cases, big tears, medium-sized tears, bursal-sided partial tears, reverse pasta, intrasubstance, in all of these cases, the ability of the exam to show us the tear is tremendously high. So it's something about 98 to 99 of sensitivity, specificity, and we are very happy with that. But what about when we think about the same idea in the anterosuperior cuff. How capable is the MRI to show us a lesion in the anterosuperior cuff? So I'm talking about the subscap. I'm talking about the long hair of the biceps. And how trustable is this exam to show us such lesions when they do exist? Well, the thing is, these things, they have been happening to me in my office so much in the last 7, 8 years that I have been studying this, and now everything is very clear in my practice, in my mind. Uh, and I have a lot of support of the literature to do what I have to do and what I am about to show you. So first of all, so what is the anterosuperior cuff? So the anterosuperior cuff means all of the insertion of the subscap together with the intra-articular part of the biceps together with with all of the parts of the biceps, we are into the bicipital groove or the biceps sheath. So see, when you have big subscap tears, like this one in yellow here, the ability of the exam to show you the tear is very high. But in the same way, when you have big tears and big dislocations of the long hair of the biceps, medial subluxation, the ability is very big. So in these cases, big tears, which are quite uncommon of the subscap, or fully complete tears, which are not really common, the answer is yes, the MRI is a very big, is a very good exam. But the problem comes, and this is what my lecture is about. Okay, the problem comes when you have small tears of the subscap and lesions of the long hair of the biceps, which are absolutely missed and not shown by the MRI. This is a personal case. I saw this patient this morning, a 42-year-old lady with a high-grade pestal lesion, but the clinical picture was evident, suggesting me the presence of a concomitant subscap tear, but the MRI was absolutely innocent. I'm not going to show all of the MRI cuts in the axial plane, but absolutely innocent. And I entered with my arthroscope and I looked for the integrity of the subscap. The lesion was there. I fixed that together with the supraspinatus tear, and the patient is doing fantastic. And I have been seeing these scenarios with a lot of frequency, which means I understand the tear clinically, the subscap lesion, but I see nothing in the MRI, but I find it in the arthroscopy. So I dare to say, many times you have very innocent subscaps in the MRI, but there is a lesion there which you can understand and see it from a clinical point of view, but the MRI misses it a lot. And literature supports us very much. So this is a recent paper about a mini systematic review about the accuracy, not only of MRI, but arthro MRI in detecting subscap tears. And what does it say? It says exactly what I see in the office for almost 10 years. Okay, so this is the important phrase. So the sensitivity of detecting a partial tear of the subscap sometimes is only 54%, which means sometimes there is 50% of chance of the patient having a subscap tear, but the MRI is very innocent. And I see it with a lot of frequency. And the conclusion of the study is this: in spite of all of the enhancements, the technological improvements, the sensitivity to detect a subscap tear is still challenging in MRI and in arthro MRI. And in this sense, the surgeon needs to be aware of the possibility of having a tear of the subscap, even with an innocent MRI, especially when there is I would say, a suggestive clinical scenario. And is this important? This is extremely important because this is the phrase. A subscap tears, as a rule, it comes together with a tear of the supraspinatus. But if you don't treat the subscap lesion, you will have, you can always have pain after the surgery, even if you have done a lovely fixation of the supraspinatus. So this is extremely important. And we have developed a way to fix it and for you never to be in trouble. This is very clear, and I want to show you guys how to think and how to act. So how should you think? Well, considering that the MRI many times misses a partial subscap tear, and considering that we have a very big diagnostic role of arthroscopy, and I am also talking about lesions of the long head of the biceps, and I'm going to show it in a few seconds. In any cuff repair arthroscopy, and especially when you have clinical findings of the subscap and or the long head of the biceps, you must systematically evaluate these structures, which mean the subscap, the long head of the biceps, and you treat them whenever needed. And I'm going to show you now a video with very, very simple to understand and pedagogical ways of doing this without trouble. So just for you guys to understand, so this is a case that I operated 2 years ago, just to show you. So that was a 72-year-old man, extremely athletical man, a traumatic tear, a big tear, something about, I would say here, 3 centimeters. But see here, the subscap was absolutely fine. I didn't pay attention to make photos of the axial cuts because they were extremely innocent. But the clinical picture was there, and I knew that in spite of the innocence of the MRI, there was something, and I was completely right. And if I didn't act like this, results would not be good, and they were, I would say, fantastic. So this is what I suggest you guys to do in all of your shoulder scopes whenever you are dealing, of course, with a cuff tear. So this is our right shoulder. First thing, you have to establish a view. So you open the capsule. This is an important detail with 2 hands to do a very big opening of the capsule. You can enter with a shaver or without a shaver. You must first of all create space. What we are seeing here is just fraying of the anterior labrum. These are just physiological alterations with no pathological value. I don't want to damage the labrum, but just create space. So I'm just taking a little bit, a slight part of it, just to create a space to start working in the same way in the root of the biceps, just to start having a work. And then I'm going to start doing something extremely important, which is I have to remove all of the anterior capsule in order to properly see a subscap and to properly evaluate a subscap. Sometimes it's very easy and sometimes it's difficult, as it was in this case. So as I am showing here, you must do a very big release of the anterior capsule upon their rotatory interval. If you don't do this, you will not properly evaluate from a diagnostic point of view the subscap. So you see here, just a second, I'm coming back here. Okay. Just a second. Okay. Yes. So I am here, and it's very important to make a very ample release of all of the anterior capsule. This is what I'm doing now. So it's very important for us not to waste time, but to invest time doing this. So the subscap is here below. I have to take all of this tissue here and all of the anterior capsule in order to to be able to see the subscap. So if sometimes it takes 10 minutes, 15 minutes max, but it doesn't matter. It's important to do this. So see what I'm seeing here. So this is the anterior capsule. This is the anterior capsule. This is the long head of the biceps. Humeral head, the subscap is here. If I don't take all of this tissue, I will not be able, I'm sorry. I'm just learning how to do this with Zoom. Yeah, yeah, okay. Just a second. Yeah, okay. So see, I have to take all of the anterior capsule until I see my subscap. But if I do a full release, it's not difficult for me to see here the tear that I was expecting to find because of the clinical picture, in spite of the innocence of the MRI. So here, what I am seeing a partial upper third important lesion of the subscap, like a letter V. If I rotate internally just a little, this is what I'm gonna see, something like a letter U, but a big partial tear. And if I don't know how to look for it, I'm not gonna diagnose it. And I can feel them, I can understand them clinically, but many times the MRI misses it a lot. So you see, now this is the healthy part of the tendon, but still another small lesion here. And if I don't see the subscap properly, I will not see the tear, I will miss it, and then I will have a lot of troubles in the future. In the same way, I have to evaluate the long head of the biceps. I do it all of my shoulder scopes when I'm dealing with rotator cuff pathology. So what we must understand, the evaluation of the long head of the biceps is never statical, is dynamical. So see, if I look at it, just a second, if I look at it, this is what I see. Some degeneration, but generally there is much more on the pulley part, and I have to abduct, and I have to put my shoulder in abduction, external rotation, and I come with a probe, and I put the long head of the biceps inside of the joint, and this is what I'm gonna see. Much more degeneration, much more lesion, and this is what literature likes to call biceps hidden lesions. So you must be aware of that. You must properly, I would say, identify, analyze the biceps, and then you will decide if you are doing something or not. In this case, obviously, I have to fix the subscap, and I have to do a biceps tendon. So this is what I do. I start putting an anchor in the lesser tuberosity. It's not difficult. So where do I put it? I always put it, this is the subscap, this is the subscap lesion, this is the long head. I always put it above the insertion of the subscap, medial to the long head, on the lesser tuberosity. I'm gonna give you guys a super trick. You don't have to use an osseous burr. You can use a soft tissue shaver, but not in oscillation, but in forward. I put it in forward and very fast, 5,000 or 6,000, and it's very fast, and it works a lot, and I don't have to use a burr. And I'm gonna make a bony bed in which I'm gonna put my anchor to fix my subscap and to do the biceps tenodesis. Whenever you put the anchor, it's very important to take care with the head of the patient, because the screw driver generally is touching the face, the chin, and the eyes of the patient. So you must take a lot of care with the face, especially the eyes of the patient, as I am mentioning here, okay? And immediately after you put that, this is something that I'm very happy to show you, because this, what I'm gonna show you now is something that made a tremendous difference in my life from 6 or 7 years from now. So whenever you can, it's very nice to do an accessory anterosuperiorlateral portal, which will help you as a waiting portal, as a working one. So this is what I'm doing now. I am creating an anterosuperior portal with a spinal needle. It helps me tremendously. The first thing I'm gonna do is exactly this. I am separating the sutures, and I am putting one of the sutures on the anterosuperior portal, which is now being used as a waiting portal. So I have seen in my life so many people having complications with one suture getting stuck with the other, and the best way for you to avoid it, put them in different portals. So now one of them is in the anterosuperior portal, and for the anterosuperior portal, I am entering with a suture manipulator, and very elegantly, I'm putting one leg of the white suture in front of the subscap. And then I just have to come with a bird beak from the anterior portal to fix the subscap. So I am picking here a healthy bite. See another trick here. See, the small tear of the subscap was here. The bigger tear was here. So I am picking up a healthy bite and very medially to that to fix all of that with a simple suture and a single suture. So this is what I'm doing now, and I just have to put that suture through here the subscap and out of the anterior cannula, and I'm gonna fix it now. And with only one suture, one dot, see what a beautiful fixation of the subscap I can do with only one suture. The vast majority of my subscaps I fix with one suture, and the other suture I can use, as I'm gonna show you now, for the biceps tenodesis. So a beautiful fixation of the subscap. And then you cut it, and then I have to do the biceps tenodesis. So what is the next step? The next step is exactly this I'm gonna show you now. First, you do the tenodesis, and after that, you do the tenotomy. This will make your life extremely simpler. First the tenodesis, and then you do the tenotomy. So this is something that I really want to show you. See how this is a super pedagogical image. Here I am seeing the supraspinatus tear, which is this one here. This is the tear, the size of the tear from this part to the footprint, which is nothing from this part, and the footprint is here. This distance here is exactly this distance from here. And whenever I have a big tear or a complete tear of the supra, it's very easy to do an anterosuperior portal. So now what I'm gonna do, I use very simple sutures. So one leg of this blue suture is gonna pass out of the biceps. So I am just delivering that from the anterosuperior portal to the anterior portal. This is something very simple. And now through the anterosuperior portal, I'm coming with a bird beak, and I'm gonna pick this suture and I'm gonna pass it through the long hair of the biceps. In my opinion, and this is something very important now, see how a healthy bite I can pick, coming not from anterior to posterior, pay attention, but from lateral to medial. This is a personal opinion. I can make a better bite of the long hair of the biceps if I come not from anterior to posterior through the anterior portal, but from lateral to medial through the anterosuperior portal. I have been doing this for years, and I did that, and then I am just delivering this part of the suture, which is through the long hair of the biceps, to my assistant, who is picking up and putting it in the anterior cannula. So now see this leg here. Now I'm gonna show you a very nice image. Is this one. So it's passing from the anterosuperior portal to the anterior portal through the biceps. And then I just have to tie the knot and cut it And after that, I'm gonna do my biceps tenotomy. So first the tenodesis, then the tenotomy, always, all of the time, Hamesha. First the tenodesis, then the tenotomy. So now the tenotomy is done. See how tense the biceps is here now, because the tenodesis is already done here. So now I will do the tenotomy in very fastly. You can do it with a basket, you can do it with a shaver, radiofrequency device, electrocautery, arthroscopic scissor, which I'm using now. This is something to be done extremely fast, and then the surgery will be finished. So then I just have to do a slight debridement here of the biceps anchor. And now I'm going to show you the final result and come to my conclusions. So this is the final aspect. See, so this is the stump, this is the supra, which still will have to be fixed. So the subscap is here, the biceps tenodesis is here. We always have something like 1 centimeter, 1.5, which means nothing, okay? And then the articular part was finished, and obviously after that I would have to fix this. The supraspinatus was fixed, and then the surgery was finished. So having said all that, I'm gonna come now to my conclusions. So I have 4 take-home messages, especially for the youngsters. First one, pay attention to your patient's clinical scenario and understand that many subscap tears, they can be there, they can really exist in the same way that many times you can have a biceps lesion, even in spite of a very innocent MRI. Literature is absolutely clear about that. I see it in the office with a very, very high frequency. Take home message number 2. So you must do all of your intra-articular analysis in a very proper order. So you must do it in a very systematical way. You enter in the joint, you create space, you remove the anterior capsule, and then you evaluate the subscap dynamically with internal and external rotation. You evaluate the long head of the biceps dynamically, as I have shown, and you do it in a very systematized manner, and it becomes easier and easier and faster with time. But this is something that, in my opinion, must be done. Take home message number 3. Consider doing an anterosuprolateral portal, especially if you have a supraspinatus complete tear, because this is going to happen to you too much. And if you do this, use your creativity to use it as a waiting portal and as a working portal. And this is my last message. And keep in mind, you must always understand and never forget, a missed subscap tear can compromise your final clinical result, even with the most beautiful suture of the supraspinatus. You can do a double pulley, you can do a suture bridge, double roll, it doesn't matter. If you miss a subscap, you will be in trouble. And in the last 3 years, I have operated 4 cases operated by other surgeons with missed subscap. I had to reoperate. The lesion was there and the surgeons missed that. And you see, you have a lot of trouble if you miss a subscap tear. So that's it. I'm very happy to be here. If anybody wants to send me an email, it's an order. It's an honor. And if you want to see a lot of nice things about shoulder, about the elbow, clinics, biomechanics, arthroscopy, trauma, and so on, please subscribe to my YouTube channel. It's a pleasure, and that's it. I'm finished.
Thank you for your nice talk. Thank you, Sergio. Always it is nice to hear to you. Thanks a lot.
Okay, I don't know. Well, Neeraj, I'm not seeing you. Oh,
yeah, here.
Okay. Okay.
Right.
Okay, sir. Sir, I hope you liked the lecture, sir.
Yeah, 2000 me and 2,500 other people from Ortho TV.
Okay, good.
मैं लेके आता हूँ, आप मत जाओ.
Right. Dr. Samantha, can I ask a question to Dr. Sergio?
Yeah, definitely.
Right. Dr. Sergio, thank you so much for such an elegant talk and video. And I must admit, I've seen you operate and you are a wonderful surgeon, and I've seen your subscap repair, and that's beautiful actually, especially the superior portal which you utilize, and that was fantastic. My question is, when you do biceps stenosis with the same anchor, it's a double loaded anchor and you're using one for the subscap, the other for the biceps. Now, a person who's going to do a biceps flexion is going to put a lot of strain on that biceps stenosis. Do you think so that compromises the other suture as well, or have you ever had any complications with this anchor, especially because it's a lot of load on the biceps?
Sir, see, the answer is very easy, because we have been asking ourselves here, Brazil, United States, all of these questions for more than 10 years. So I have the answer, and the answer is, whenever I have a very heavy, I would say a high demanding patient, especially a man with 60 or less, and I know that his demands are gonna be very huge, I do a sub-pec tenodesis. So you see, this guy, he went back to the gym, but he's 72. He's very happy. I have videos I can show you in, WhatsApp, it doesn't matter. But the thing is, I thought about doing a sub-pec tenodesis, but you see, in a 72, I thought it was too much. But see, in the vast majority of the cases, this kind of suture to me is enough, but only one. I have been doing this for 10 years, but if I am operating, is basically it's never a woman, it's a man who likes to go to the gym and doing sports. You see, if he's very active and young, I do different. I do a sub-pec, and the thing is, just one thing, how do I do it? I enter with the arthroscope. This is a super tip in my opinion, and if you think differently, please tell me. I enter with the arthroscope, I cut the biceps in 5 minutes, and then I stop it, and then I do the sub-pec open, in open fashion, and then I finish it, and then I come back to the arthroscopy. So many people say, but why don't you do the open part in the end? Believe me, is a pitfall, because the shoulder is gonna be a watermelon, a lot of swelling, and it's gonna be very difficult. So I do it in 5 minutes, I cut it, and then I do it open, and the shoulder is basically, I would say, it's basically dry, because you have made 2 minutes arthroscopy, and then I close it, and then I do the subscap, the supraspinatus, blah, 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 blah. And the only thing is that there are some people who are able to do the sub-pec biceps tenodesis arthroscopically, but I don't have these skills. And you see, I'm so happy with the mini open. I would say it's 3 centimeters. And so, but if you are doing this, my tip is start arthroscopically, 2 minutes, 5 max. You cut it and you stop. You do the open part, you finish, and then you come back and you do all the rest. Okay?
Okay, even I agree completely with Sergio. And I have seen young Alri operating that he also does the sub-pec, like open, but he does it at the end of the procedure. But it's a good trick for everybody that you can make the subscap done, the sub-pec done, then you can go back to the cuff. Yes, Vivek?
Yeah. How do you fix your biceps in the sub-pec region? Anchor, interference screw, or it is a soft tissue tenodesis?
This is the question, and the answer is very good. See, I'm gonna give you a very nice answer. The best method, in my point of view, is nothing but transosseous sutures. Much better than screws, much better than soft tissue. I have done it with screws. but sometimes the screw have, my tendon was broken, and I got desperate, and I ended doing a tenodesis on the conjoined tendon as a salvation procedure. So after discussing with my friends, we said, well, how can we get out of trouble? So I do 2 perforations, okay? And this is the trick. I do it with number 7 drill of the ACL kit, like you do in the tibia. So why number 7? Because with number 6, sometimes the biceps is not passing. So with number 7, you will never miss. And to avoid, and this is something that I think it's interesting. So see, just a second. This is the humerus. So I don't do the 2 holes in the same level to avoid a stress fracture. So one up and one down. Something like 1 centimeter, 1.5. It makes sense in my mind to avoid a stress fracture in between the holes. Yeah, maybe I am thinking too much, but it makes sense in my mind. And then I pass it, and to connect these 2 holes sometimes it's difficult, but you spend 10 minutes with a curette, or do you know the bacaus, and you come that, and you do something like this for 5 minutes to connect the incision, because the intramedullary channel, it's cancellous bone, but it's very strong. I'm talking about strong man with good bone quality. But you connect them, and then you pass, and I suture with Ethilon, with number 3 Ethilon. Super cheap, and believe me, Charles Neer used it to say, nothing is better from the supraspinatus tear than transosseous sutures. So I am using the same idea in the subpec. I guess I am doing the right thing. It's super cheap, and it's absolutely fine. I have wonderful results with this technique. The tendon is not gonna break because of interference screws. I tried to use tibial screws, okay, from ACL. But the thing is that they are made for ACL. They are not made for biceps. So my tendons were breaking all of the time. I was angry with that. I discussed it with my friends, and then we said, let's do transosseous, and it's done.
The problem is the interference screws, okay, of any other place cannot be used in that place. I'll tell you why. These interference screws are designed for a cancellous bone, not for a cortical bone. And the place where you are actually doing the biceps tenodesis is a cortical bone. If at all we have to put that, we have to actually have a little. So if your, let's say, diameter is 6, you need to make a 7 mm diameter, and you need to have a tap, which 99% of the companies do not supply because they have not created a tap for that. Okay.
Because in the tibia is not needed, huh?
Yes. In many cases, I have ended up doing a soft tissue tenodesis with the pectoralis major, especially in those cases where they are just concerned with the deformity and not with the power. Let's say 55-year-old male. I recently did for a doctor. He's 55. Okay. He's not concerned with power. He's a physician, but he is concerned because he's always using a half sleeve shirt. So he doesn't want a popo deformity. Now, why should I make a hole? I just suture with pec major. What do we do in all the proximal humerus fixation? Nobody does a anchor tenodesis or a tenodesis with the interference screw. Everybody does a soft tissue tenodesis.
Yes.
So I have come to realize that unless my patient is very young and he really needs some kind of a biceps power, even in anchors and interference screw, there's a 30% to 40% failure. Okay. I have been doing soft tissue tenodesis, no complaints. So I've stopped doing all this business.
Okay, but the only thing is this, you see, well, just a comment. In the Amazon, we operate a lot of military people. So people from 45, 50, but they are very, very strong. And I am afraid of doing a soft tissue tenodesis, and I am afraid of failures. And in my mind, there was a beautiful study by a guy from California called Richard Ryu. And he said, if you want to get out of trouble with very strong men, do transosseous sutures. I am being very happy with that. So
Agree with that.
I'm not thinking about changing very strong man.
Transosseous is still far better than butchering it with the anchors and probably the interference screw. It's far better. I agree.
Yeah, Vivek, as you told, the screw fixation in the cortical bone is very dangerous. There may be laceration. Sometimes there may be a fracture also. You are making almost a big hole at 7 mm for the 7 mm screw. Literature. So what they suggested was you make a centric hole in the humerus, put a screw. Later they found out that if you make it a eccentric, there is a chance of getting humeral fracture. And the central hole, they suggest a central hole and then you put the screw. But later they have compared with the soft tissue tenodesis with the subache bony tenodesis, there is no difference. So I think Joe's technique is little different and the different planes, and he is connecting the both this one, and maybe 7 mm is a very bigger. So instead of getting a 7 mm, around 3 to 4 mm and connecting the both holes and having
biceps will not pass if it is
it won't pass, but maybe you may have a small gutter rough in the cortex and put it there and the
just a second, sir. For 10 years, I've been trying to do with 3 mm, 4 mm, 5 mm, and I can guarantee to you, if you don't use 6 or 7, as Vivek said, it will not pass. It's
bones.
We can take the questions, Manish. We can take the questions from Neeraj. You can direct the questions to Manish.
So, Sergio, there is a question. Can I ask?
Yeah, go ahead.
Yeah. So there is a question that the person asked that what is your threshold for subscap repair? As you mentioned, there are around 50% cases you will have a partial tear. So if it is a complete tear or a high-grade tear, it is straightforward surgery. What is your threshold for partial tear, say, whatever you are mentioning in your data?
Sir, I didn't understand your question. I didn't.
Will you repair every subscap tear that you find may be a small partial tear, or you have some criteria too?
That's a very good question. The question is, will I sometimes consider just a small debridement? Yeah, the answer is yes, but it must be very, very, very small. In my opinion, it's case by case. If it's very, very, very tiny and I don't see this insertion, then it's debridement. But if I see any kind of this insertion, I prefer to fix it and not be into trouble. You see, sir, Vivek knows my phrase that medicine is not black and white. It's 15 shades of gray. So the thing is, it's not mathematics. You must see it, you must analyze it with your eyes. And well, this one is very tiny. I'm just gonna do a debridement. But if I see sir, fraying without this insertion, I will do debridement. If I see this insertion, I will fix it. And I prefer, I'm very serious about that. I prefer to fix a little bit more than maybe would not be needed and to sleep well. If I see any small thing in the subscap, you will never regret of fixing it, but you may not regret, but you may, I would say, regret of saying, oh, I could have done something more. Vivek wants to
Samantha sir wants to say something.
I want to give a small logic for why Sergio is telling this. Because subscap tear, if it is a small one, basically your medial pulley is gone. And once this medial thing is gone, your biceps is the dynamic per thing. What goes on, and that accelerates the subscap tear. So if you are going to R on the R anyway, you better R on this fixing the upper part of the subscap. So that saves your life. That is the single line answer to Sergio.
One more question to Dr. Sergio.
Vivek wants to speak, sir, and then you speak, sir.
There is I completely agree with Samantha sir and Sergio. I think 3 onwards. So 3, 4, and 5 definitely needs fixation in by and large in most conditions. The question always comes to 1 and 2. Now, 1 you usually debride it. Sometimes as Sergio said, what do you do for the 2? There's only one subgroup of patients whom I leave to. I'll tell you who is that. So in the 2 with the pulley damage, I just do the tenotomy, required tenodesis. They are the subgroup of people who have got stiffness. Now there's only one problem with the biceps, with the subscap. When you do the repair and you by chance over tension it, these people find extremely difficult to get back the external rotation. Now, if you have a patient who has got a traumatic rotator cuff tear or whatever with lot of adhesive capsulitis, and you do a very tight anterior repair, it is a worse thing. So in those cases, you do the tenotomy, maybe you can debride and leave it. Let's say the group of 55 to 60. Now 55 to 60 is okay, they will manage. But if the same person is 35, then I would still fix it because he has got a very long way to go. And I don't want to leave it 2, which will become 3 and probably 4 in another 5 to 10 years. So as Sergio said, there is no black and white. There are a lot of shades of gray. Use your judgment, common sense, biomechanics, history, literature, and take the on-table call. That okay, I need to fix and I need to
biceps is the enemy for the type 1 and type 2 tear, Sergio.
Yes,
Excuse me, sir.
Biceps is the enemy, dynamic enemy of the type 1, type 2 subscap tear.
That's why you do the tenotomy, half your animosity is gone.
Sir, there is no person in planet Earth that kills more biceps than I do. You know,
you are
sir,
French.
Sir, the biceps has 10 functions in the shoulder. Pain, 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 pain. Trouble, 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 trouble. You see, there are many papers in literature about that. This is a beautiful discussion. But the thing is, if I see a subscap tear, for sure, the biceps sheath is compromised, as you have said, sir. Yes. So see, if you kill the biceps, you will fix it forever if you do a tenodesis. If you leave it, you may have big problems in future.
Do you also know one thing? Because we always do the ultrasounds of all these patients at 3 months, 1 year, and then subsequently every year as far as possible, because we have very strong follow for rotator cuff tears. And I have realized that the re-tear in a single row repair of the subscap, the re-tear rates are as high as 25 to 30%, as high as, okay, but lesser reported because a lot of people, because a lot of people don't do these scans. Now the problem is, they have no symptom, absolutely normal. If supra and infra has healed, even if there is a small re-tear in subscap, they have no problem because you have killed the biceps. As Sergio said, they have no pain. Only sometimes if it is a type 4 tear, then they find difficult to tie their nada, the trouser nadas, okay, the strings of, otherwise they are fine. That's why the subscap re-tears remain asymptomatic. They don't say anything because you have killed the biceps.
Girish, you want to...
One more question, sir. In chronic tears, there will be delamination of this tendon, and that will be extending up to the muscular tendinous junction. At that time, how to fix it? And do you do a coracoplasty regularly?
The question is to me?
Yeah, sir.
What is the question?
Sir, see, the answer is easy. I never do the coracoplasty. This is something that, in my opinion, very few people are doing. I never did it, to be very honest. But see, big retracted tears of the subscap, they are very uncommon. But if I see them and I can do nothing intraoperatively, do you know what I do? I do nothing. You know, so you see, it's very uncommon, in my opinion, to see a tear of the subscap in which you enter, just a second, Vivek, in which you enter with the arthroscope and you say, oh, this subscap is absolutely gone. But if that happens, I do nothing and I leave it like that. And just a second, in these cases, the biceps is always dancing in front of you, absolutely stable. And if you don't do a tenodesis, this patient will have pain forever.
Girish, I think, Girish was asking Sergio about the delamination. Now, delamination Delamination, Girish, is extremely rare in subscap. It usually happens in the supra and more so in infra. And you must listen the lecture of Swarnendu sir, and we have published a paper in IGO. Okay. So if the delamination is at the same level, means superior and inferior level at the same level, you can do the N mass suturing. Take all the layers together. But often, but not very frequent, you will have the inferior layer more medial. If it is not coming to the same level, then you can't suture it together. Then what you do, you suture the inferior layer separately by putting a medial most anchor, and then you suture the superior layer separately. Okay, but delamination, in fact, in subscap, you see the splits like this. Okay, you will see the split like this, but getting a delamination, two separate layer of subscap, I am yet to see one. Maybe I missed it, but you will find very commonly.
I've come across two such cases with delamination.
It is not a
I think last webinar we have with Vivek. Probably you have not attended that meeting. I will send you the video. Thing is that it is a delaminated tear. It is a Sugaya's technique is there. So you fix the deep layer into medial side and the lateral to the lateral side. So you have to fix both. Otherwise, the tear is very, very high.
Actually, there is one theory, why it is important to fix the inferior layer. You see the inferior layer, the lowest part is actually nothing else but your superior capsule.
Capsule, yes. This is the capsule.
That's why it is important that you must fix that, because in a way you are strengthening the superior capsule. Okay, see, capsule and cuff are merged. Okay, and the inferior most layer is actually merged with the capsule. So you got to stitch it if possible. Sometimes it's very bad, then you have to say, okay, I'm leaving it. But 99% cases you will be able to fix.
Another one trick I want to give you to Girish is that because in chronic cuff tear, believe me that this is a sugar paper even. The superior part, that means the dorsal side cuff will be thinner. The lower part will be thicker because this is of the chronicity. Because because it is attached to the capsule, it will never go into atrophy. Rather, the superior dorsal part will go into atrophy, then that will be the thinner part. So if you don't repair the lower part, which is bit thick, then your upper part, if you fix it, it is 100% is going to fail and re-tear. Agreed?
Yes. Yes.
Yeah, hello. This is about the subscapularis. Vivek has told the tight suturing of the subscap will give external rotation deficit. So problem and stiffness. So what I do is because subscapularis superior part is widened, very important part. If it is a torn superior part, I do like a speed bridge type of technique, a low profile repair, so that you won't have the external rotation stiffness.
Understood.
I agree, Jayaprasad. The problem is it's just feeling. I have not actually assessed them clinically, everybody. That is probably one drawback I have in my statement. I should have assessed everybody, but that's just somehow feeling that it's already tight in the front. Okay, I have already done the capsular release, and on top of that, again, if I tighten the subscap, it may lead to that. Though I agree that it might not have led. So that statement has to be judged with a lot of caution.
So
yes, sir. Swarnendu, sir.
Manish is going. Manish is the key. Manish.
Sir, next question is coming. So can we move on to the next question?
Yeah, obviously, move on.
Okay. So the next question is, how do you decide the number of anchors you are going to use for the subscap?
It depends upon if you classify the subscap tear according to the LAFOS, if it is a type 1 and type 2, even type 2, then probably one anchor. And if you goes beyond type 3 and 4, 5, then use 2 anchors. It is not necessary that every time you go with the double row or whatever. Even subscap can be jolly well be fixed with single and single anchor, like single row. I am meaning single row.
So Vivek.
One important thing about subscap to be remembered, which everybody ignores. Subscap is the only muscle among all the cuff which has got the largest footprint. Okay. And everybody thinks that just by putting one anchor, you are restoring. You are not restoring. Number one. Number two, if you are not comfortable doing arthroscopic, no problem. One of the best ways, when Saji was showing, once you have done the cleaning, entire debridement, you can put a traction suture on the top, okay, on the apex. And then the same anterior portal here, you can extend it. Once you extend, you can actually see the traction suture. If you have a traction suture ready, you will know exactly where is the apex. See the whole area, repair it nicely if possible, because inferior anchor is very difficult to place, especially I'm talking about the newer surgeons. A very experienced surgeon can do 2 or 3 anchors, but a new surgeon will find extremely difficult to place the inferior anchor. And inferiorly, it is muscle, it is not tendon. So take a perfect bite, do the Mason Allen repair is not easy. So don't be shy, just open, do a perfect repair, because if subscap is not repaired perfectly with a single anchor, some 2 suture you want to do, it's going to fail.
Sergio?
No, I just want to say something. In my life, I have put 2 anchors only once, and the only thing that I want to highlight is that you see, even Burkhardt, who is the king of double row, he says that you don't have to do a double row in the subscap. But the thing is that I just want to mention something. I have done so many cases, and in my opinion, the space to put 2 anchors on the lesser tuberosity is very small. So it's very difficult, in my opinion, putting 2 anchors in the lesser tuberosity arthroscopically. It's very difficult, and not because of a matter of ability, of a matter of space. And I would be with a lot of fear of creating a fracture between the 2 anchors, and then I would be gone. So I think it's much safer to do. But to be very honest, sir, 1 anchor in the vast majority of the cases does the job, sir. I am absolutely
Yes, Sergio,
tranquil to say that.
Sergio, I want to that referring to the king of this thing, this Burkhardt. I was lucky to work with him for some time. So I believe in that theory that it is better to give the single row rather than having the 2 rows for the subscap, because that is too much for the subscap. Yes.
Okay, so I think the time doesn't permit us. So last question, in 3 minutes we have to wrap up the session. And the last question is about the rehabilitation post subscapularis.
Only subscap or with the cuff?
Or we extend the question to with the rotator cuff, complete rotator cuff tear, or the isolated subscap.
Yes, I think that will be better, because subscap is not that frequent. It's better to go with the only cuff. Sergio, how many days you put your sling?
You mean in this
rotator cuff, or not the subscap, only your supra?
4
weeks.
4 weeks, and see. If I have an old patient with a massive tear, and I do a lot of cases in which I do a medialization of the footprint, and it's not uncommon for me to do that, then I use an abduction sling for 5 to 6. In older patients with big tears, especially when I have to medialize the footprint, I am much more conservative. Then I keep 5 to 6 abduction sling. But as a rule, 4.
Okay. So I also
any different opinion?
I whatever cuff I am doing, I am using that abduction sling, and that has been because I was there with sometime for observership with great band Laurent. So he uses simple technique, just take a 400 milligram cotton ball and you cotton roll and just keep in this stockinette, and that becomes your abduction thing, and you don't need the fancy costly the abduction splint for your cuff.
Yeah.
Can I tell you one biomechanical reason why this abduction sling? Because we have just finished a study and we have been in the process of writing. When you put an arm in 30 degrees of abduction, it increases the blood supply at the footprint. There's a biomechanical study. If necessary, I can share with one of. Yes. Okay. And that increased flow of the blood is supposedly helping healing. Healing, no one knows, but probably presence of bit of blood helps in washing out those substance P and other substances which are possibly causing the pain. And secondly, when you do the abduction, you have kept your repair in slightly lesser tension. Now tension creates a lot of pain. In many of my patients, when we did the study, we realized that those who had abduction pillow had less pain, post-op pain. Okay, but that is only for the bigger tier. I'm not talking about the smaller tiers.
Manish, we have to conclude. Manish, you just give it the conclusion remarks. And Girish,
Sir.
give the concluding remarks.
Yeah, usually what Dr. Vivek said, the
Hello?
abduction, what I've observed is, hello, what I've observed is, if we keep in abduction, the post-operative pain is very less, and the mobility also, the post-operative rehabilitation is much more easier when it is in abduction.
Can I make one last comment? Actually, I operated on father and father-in-law of one of my known person, and father-in-law I did not give abduction pillow, and father I gave just by it just happened by chance. Father-in-law still had a lot of pain. Father did not.
Manish, you conclude.
By chance.
Manish,
Okay, sir. Thank you.
I think it was a great.
I thank everyone for giving the time for making this session worthwhile. Hello.
Neeraj.
Yeah, I'm here. Can you hear me?
Yeah. You can.
Yes, Neeraj, we can.
You can now conclude the meeting. End of the meeting. Yeah.
Okay. We thank you all for coming here, and especially Dr. Sergio for being awake till so late. It's almost, I think, 3 a.m. there.
That's normal.
And we thank Mr. Anup. Yeah, we thank Mr. Anup for Sironics from Sironics Arthroscopy Solutions to bring this webinar to Ortho TV. And we thank all our viewers, approximately 3,000 viewers who saw this webinar online. Okay, so let's see you in the next webinar. Thank you very much. Bye-bye.
Bye-bye. Take care.